A couple quick announcements. We are videotaping this and every other meeting, and it will be available shortly after the meeting on www.okhouse.gov, and all of the other meetings have been videotaped, and they are available on the website as well. Today, we have speaking before us a coalition of healthcare providers. The way I'm going to do this in an orderly fashion, we have 6 presenters. So members, I am going to let all 6 presenters speak. And after those 6 presenters speak, we are going to open it up for questions. I will leave questions open as long as is necessary, as long as we still have questions. I do want to announce that Representative Rosecrans could not be here today. He has requested that I allow Representative Dolans, my friend from South Oklahoma City, to sit on the panel in his behalf, and that's absolutely okay. So we will recognize Representative Dolans as if he is a member of the committee. And Representative, since you are sitting where Representative Rosecrans normally sits, here's the secret: I can't see you behind them, so text me to get recognized. Jacob knows that, so that way I know where everybody is. Members, what I would like to have happen today, and for guests that are here today, I have said this over and over again. I want to say it again today. This is your capital, and we are thankful you came here today. We are thankful that you decided to come watch your government at work. What I am going to ask you is the same thing I asked with the presenters. As is the custom of the House, we don't have responses from the audience. We actually really don't do that for us. We can take it. Believe me, you get elected long enough, you've been called every name in the book, whether you deserve it or not. And what we do it for is the presenters. It is, and as I talked to several of you that presented from the public, you did a great job, but it's very nerve-wracking. So we do not have responses. I'm going to do my best to keep us on task and on target for time. We may or may not take a break before questions for members to collect their thoughts. But that's the plan, so I think everybody knows. I have a list that I'm going to be moving forth that was put forth on oksenate.gov and okhouse.gov if you want to follow along. For presenters, it is very important you speak into the microphone. We have lots and lots of people listening online. And if you don't speak into the microphone, about 12 of them text me at the same time. So please, for my sake and my concentration, I would like for you to do. And I do want to point out my co-chair, Senator McCourtney, the only reason he is not here is he is part of a panel selecting the Teacher of the Year award for this year. But he has been involved in every step and is doing a great job as my co-chair. So at this time, I have been requested by Senator Irvin Yin to introduce the presenters, and I have agreed that he can make that introduction. So, Senator Yin, you are recognized.
Thank you, Mr. Leader. A lot of you in this room have heard me make many, many comments over the last 3.5 years about medical marijuana. This started back 3.5 years ago when the leader and I had the CBD bill. And of course, I had a medical marijuana bill back in 2017. So I've learned a heck of a lot about marijuana over the last 3.5 years. I'm certainly not an expert, but I think I know more than the average Oklahoman. And perhaps I know more than the average legislator as well. But I want to reiterate that today at this presentation, we've got some people that know way, way more about marijuana than I do. And please, please listen to them. And I want to reiterate that the medical community and these people today are not against medical marijuana. They're actually for it, but they just want to do it in the proper manner. 788 was titled Medical Marijuana. And, you know, if it's medical marijuana, let's have the people who know medicine involved in this. The first speaker that we're going to have is Dr. Jean Houshair, and she's actually the current president of the State Medical Association. And she and I have had many, many conversations, and I think she probably now knows way more about marijuana than I do, even though I've been studying it for 3.5 years. But she's going to talk about medical practices and standards.
Dr. Houshair, you are recognized.
Thank you, sir. Give me just a moment. Okay, we are there.
And Dr. Househair, while you
Yes,
do
sir.
that, I do want to make a quick announcement. You can see, there was a slideshow presentation. Members of the audience, you can see it here. You can also see it on the two back screens. So there's several places to watch it. You may proceed, Doctor.
Thank you so much. Good morning, Leader Eccles, and esteemed legislators in the room serving on this panel. On behalf of physicians and healthcare leaders throughout this state, we want to thank you for allowing us this opportunity to have a conversation this morning with each of you about Oklahoma's medical marijuana program. You'll need to advance it. Upside down. Thank you. My name is Dr. Jean Househair. I am president of the Oklahoma State Medical Association. Joining me today are other state leaders in the areas of pulmonology, pharmacology, psychiatry and addiction medicine, toxicology, and public health, as well as members of the 18 organizations who make up our medical marijuana coalition. The subject of medical marijuana does remain complex, and one that deserves not just today's conversations, but also thoughtful consideration and legislation to ensure that we get this right. Our coalition believes, no, we know that this can happen. As the great football coach Vince Lombardi once said, people who work together will win, whether it be against complex football defenses or the problems of modern society. Oklahoma's medical community supports compassionate medical marijuana and cannabis derivatives. We have proven our support in the past by working with Representative Eccles to advocate CBD legalization in our state, and we stand ready to create increased research of medical marijuana at both the federal and state level. We did oppose 788 because of concerns with its unreasonable short timelines in implementation. These concerns continue to be valid. We are grateful also for the physicians that spoke to this group last week, sharing their concerns about this program as it is currently structured. Today, our coalition hopes to provide you each with meaningful solutions that you can contemplate. So, why are we here today? Since this program directly impacts patient care, public health, and physician standards, Oklahoma's health community must have a seat at this table now and moving forward. Oklahomans expect and deserve that simple ask. With that in mind, we come before you with three essential goals. Number one, guard patient safety by adopting the same standards used with other medications used in the treatment of medical conditions. Number two, ensure patient access through a clear system of safety and liability controls which address providers' concerns. Number three, ensure public safety by developing safeguards such as consistent product labeling, controlled access, and preventing secondhand smoke. I come today to you speaking as a concerned doctor of medicine, as the president of the Oklahoma State Medical Association, and a representative of this marijuana medical coalition. The opinions and information in my presentation and those of my co-presenters are on behalf of our coalition and do not necessarily reflect the views or the policies of the universities that we work for, hospitals, or our employers for which we are affiliated. First, I would like to address the phrase that has been used frequently throughout this discussion, accepted medical standards. Had the organizers of 788 consulted with our medical community while drafting this petition, or at any point during this campaign, they would have learned the phrase, that this phrase is very loosely defined. Instead, let's take a look at the normal steps a physician or any healthcare provider takes when prescribing medications. These examples are really just simplified as an overview, and in reality, the number of steps that typically vary by patient complexity, medications, schedule levels, access to medications, physician and patient discretions, as well as practice of medicine variables. So as you can see, even average long-term prescriptions, such as those for blood pressure or cholesterol, require an average of 7 steps. So the number of 7 steps remains similar when a physician prescribes medication for off-label use. Off-label use of medication simply means that a physician is recommending a given medication that has shown promise to treat an ailment for which it has not been approved or perhaps wasn't originally created for. So off-label is used with caution and only when medically appropriate. The type of prescription that provides the most steps is for medications that have been classified as controlled substance by the Food and Drug Administration, also known as the FDA. Controlled substances are drugs that are classified as Schedule II, meaning the medications have medical benefits, but also have high risk of chemical and psychological dependence. For these particular medications, doctors are always required to exercise extraordinary caution. This means extra steps are required, such as entry into the PMP, which is Oklahoma's prescription monitoring program, and short-term prescriptions with monthly renewals if needed. So for that reason, there are at least 10 steps when physicians prescribe controlled substances. So focusing now on Oklahoma's current medical marijuana, which still remains listed as Schedule I controlled substance by the federal government. Schedule I means it is known to carry the highest potential for abuse and addiction and cannot be prescribed. From the way things stand at this moment here in Oklahoma, physicians only are to take 3 steps to recommend this controlled substance drug to our patients. As things stand now, physicians will have no control on behalf of our patients regarding marijuana strength, strain, THC levels, dosage, or even delivery methods. In addition, we don't know which of the 799 known strains of marijuana will be available here in Oklahoma, and therefore cannot know how our individual patients will be impacted, be that good or bad. All of this makes it virtually impossible for doctors to appropriately counsel patients as to best uses and possible side effects. And with no follow-up required, we really can't appropriately monitor patient progress or potential or ongoing drug interactions. We remain highly uncomfortable being put in the position of having no idea how any of our patients are in fact doing. If you take a look at this chart, you'll see how outside the norm or accepted medical standards, Oklahoma's current medical marijuana program truly is. It's on the very bottom line. So it's concerning and it's very unusual. So why does any of this even matter? At its heart, 788 directly contradicts the standard medical definition for standard of care. Without the allowance for dosage control, follow-up, or even a basic list of approved medical conditions, it's fair to assume that fewer healthcare providers of any kind will feel comfortable recommending Oklahoma's medical marijuana program. This will not only impact patient care, but also greatly limit patient access. Furthermore, current Oklahoma medical marijuana law doesn't define the bona fide patient-doctor relationship clearly. Instead, it leaves it open for an interpretation that is more transactional and business-based, with less patient care as the focus. We should update our statutes and rules to ensure that medical marijuana patients receive much more than a transactional relationship when they receive their Oklahoma medical marijuana card. So the very first line of the Hippocratic Oath that all physicians take is, first, do no harm. We take this very seriously. Both MD and DO physicians are held to similar high standards when it comes to patient safety, with our associations and licensure boards reinforcing this in their code of ethics. It is this code and our commitment to patient safety that guides our concern about widespread access to drugs like medical marijuana and ensuring Oklahoma gets this program right from the start. That being said, we know there remains potential for ongoing compassionate treatment with this class of drug, medical marijuana. The limited research available has shown medical marijuana can be an effective treatment for a handful of conditions, one being epilepsy and other seizure disorders which are unresponsive to other forms of treatment, nausea and vomiting from chemotherapy, unresponsive to other forms of treatment, muscle spasticity, such as seen in diseases like multiple sclerosis, Parkinson's, and cerebral palsy, relief for terminal illness, so people who are expected to live less than a year, as well as wasting syndromes from HIV/AIDS, as well as cancer. However, we must be careful that we do not go from limiting medical marijuana treatment plans to opening the doors here widely to just anyone who unknowingly believes it to be a panacea. The risk for potential harm remains great for patients who have a propensity for certain mental illness, such as schizophrenia, or who are pregnant or nursing. In fact, patients may simply not realize that they have any of these propensities for mental illness or addiction. And marijuana can create permanent and unrelenting illness. Ingested cannabinoids affect a number of receptors in the body, such as found in the brain, the central nervous system, and even the gut. As you can see, marijuana affects the brain in many ways, some positive and some negative. The impact is dependent on the method of ingestion and THC levels of the product, and some patients see a great improvement in their underlying muscle spasms and increased appetite for those having cancer or HIV/AIDS, for example. But nevertheless, these are side effects that merit close monitoring. These side effects can be debilitating, such as paranoia, panic attacks, slowed reaction times, while others can carry a longer lasting impact, such as memory loss, decrease in IQ or intelligence, and impaired balance. So what makes marijuana unique as a medical treatment is its effect on the endocannabinoid system. Discovered back in 1992, the endocannabinoid system consists of receptors that bind with cannabinoids, or more than 104 chemical compounds, and serves to drive certain reactions. In addition to the cannabinoids, there are more than 500 known chemicals found in marijuana. Patient reactions vary greatly according to age, overall health, other ailments, existing medications, and THC levels of the plant and even the strain. Last week, there was some discussion of the FDA-approved medications that are derived from medical marijuana or a synthetic version of it. 4 cannabis-based drugs have been approved and have shown promise. In addition, non-THC cannabinoid derivatives such as CBD oil have shown much of the same benefits as marijuana without the mind-altering or addictive effects. As a whole, healthcare providers rely on vetted research as an important tool to determine the effectiveness of new treatments, new uses of older treatments, and the side effects that develop with use of one or more medications and treatments. As you can see, clinical studies, which are used to monitor a drug's potential, undergo a rigorous multi-step process. Although there are literally tens of thousands of studies available on PubMed, very few meet the standards required by highly educated physicians to determine if a drug or treatment is safe and effective for humans. In fact, a 2017 review of more than 10,000 studies by the National Academy of Science, Engineering, and Medicine revealed only modest evidence for the effectiveness of cannabis to treat nausea and vomiting in adults undergoing chemotherapy and to alleviate spasms in multiple sclerosis. A no conclusive evidence list of illnesses included epilepsy, inflammatory bowel disease, Parkinson's disease, post-traumatic stress disorder, anxiety, and insomnia. And I'm going to quote, for these conditions, the report says, there is inadequate information to assess their effectiveness. Unfortunately, even those more than 10,000 studies don't tell us much because in most cases, they're based on very small sample size and limited scopes. Because marijuana is a Schedule I, federal law makes it difficult for researchers to study marijuana with the same kind of rigor that we would for any other investigational drug. The American Medical Association and the Oklahoma State Medical Association, among many others, have already adopted resolutions urging our federal Congress to reclassify marijuana to allow for better, greater research. But as it currently stands, our hands remain tied. What few studies that have been approved are limited to only using marijuana from a federally supported grower located only at the University of Mississippi. So, what's the solution? So our coalition has a number of recommendations on ways that this program here in Oklahoma can be made better and safer for patients and provide the ease of mind needed to encourage more physicians to participate. Oklahoma must form a regulatory medical marijuana board, including patients, physicians, and health researchers, in order to develop best practices and clinical standards, evaluate effectiveness of treatments, make patient safety and caregiver recommendations, and review scientific research methods and outcomes. We need to establish a list of qualifying conditions based on known outcomes and allow physicians to be able to withdraw a particular patient when appropriate. Recommendations such as in instances of misuse or addiction or otherwise severe health risk to a patient. We need to require physicians to provide in-person exams only within their established office locations to medical marijuana patients. Physicians may not have ownership in a dispensary or conduct medical exams within a dispensary or telemedically. Patients must keep follow-up exams to safely assess ongoing interactions and treatment effectiveness as a requirement for their renewals. Establish a physician registry and require annual education. And finally, allow medical boards the authority to provide guidance on medical marijuana regulatory and safety issues. At this time, I'd like to turn this conversation over to my colleague, Sir Dr. Bob McCaffrey, who is invited to speak on the impact of smoking marijuana and secondhand smoke.
Dr. McCaffrey, you are recognized. If you will introduce yourself when you come up to the podium, please.
Okay, thank you, Mr. Chairman, and members of the legislature, and all the guests here. I'm Bob McCaffrey. I'm a professor of medicine at the University of Oklahoma, although I'm not speaking for any of my employers. My specialty is lung disease and critical care medicine. I'm also involved with the Oklahoma Tobacco Research Center, part of the Stevenson Cancer Center, and I'm also on the board of directors of the North American Quitline Consortium. Again, we appreciate this opportunity and appreciate the very important job that all of you have in listening to all the opinions and information about marijuana. As Dr. Hauser said, I'm going to speak specifically about smoked marijuana. We know that that is one of the most popular forms of delivering marijuana, but we're speaking about medical marijuana. And smoke is smoke. Both tobacco and marijuana smoke. In recent studies done at the University of California, San Francisco, have demonstrated that the effects on the blood vessels are similar, whether that smoke comes from tobacco or from marijuana. And the fact is that the marijuana smoke has very much the same chemical composition as tobacco smoke. It has all the cancer-causing agents in it. There are some differences in the concentration of these agents. For example, marijuana may have up to 4 to 20 times the amount of ammonia in it as tobacco smoke. But while there are differences in some of the concentrations, all those substances are present, both in tobacco and in marijuana smoke. The difference, the largest difference really, is in the tar that comes from marijuana smoke. That is the particulate matter in smoke. And the tar in marijuana smoke is at least 3 to 4 times greater than tobacco smoke. And for those of you listening, I'm sorry that you can't see this slide, but it shows that in graphic form, the amount of tar delivered to the lungs from tobacco or marijuana. And for those of you listening, there's just a little bit of blackness of the lung from tobacco and a large degree of blackness in the lung from marijuana in this slide. Now, as you know, we're really speaking about patient safety. And the fact is that there are a lot of drugs delivered or can be delivered through the lungs. And in fact, we know that both for nicotine and for cannabinoids, these are absorbed very rapidly into the bloodstream when they are inhaled in the lungs. There are other medications as well. And in fact, as a lung physician, a lot of the medications that we use are in fact delivered through the lungs through various types of inhalers. But the fact is, when it comes to marijuana, and in fact the same is true for nicotine, there are several safer delivery methods for the cannabinoids, including ingesting them, topical preparation, and aerosols. And yes, there are devices to aerosolize marijuana in a much safer way than smoking it. And that way you also get the rapid effect at the onset and effect of the marijuana. Now, perhaps just as importantly as the mainstream smoke from marijuana is the secondhand smoke. Now, we all know that secondhand smoke is known to endanger the lungs, the heart, the blood vessels, and secondhand marijuana smoke carries exactly these same risks. In fact, we know that THC from secondhand marijuana smoke can be absorbed by those around somebody smoking marijuana. THC has been found in the bystanders' blood, urine, and sputum. And in addition, the mind-altering effects of THC have been measured in bystanders of someone smoking marijuana. Secondhand smoke from marijuana also contains particulates, that is the tar, if you will, that can be breathed into the lungs, and there are demonstrable changes in lung irritation, asthma attacks, and other respiratory infections. This can be seen to exacerbate other health conditions, particularly people with asthma, chronic obstructive pulmonary disease, bronchitis, and other respiratory diseases. One of our major concerns, though, is really in children, because when children are around smoke of any type, secondhand smoke of any type, we know that, at least, and this is for marijuana smoke, 1 in 6 infants in a recent study, infants and toddlers admitted to a Colorado hospital with coughing, wheezing, and other symptoms of bronchiolitis tested positive for marijuana exposure. And this is a great concern for all of us, for all kinds of secondhand smoke. You know, more importantly, or just as importantly as this, I've spent most of my career working to try to reduce these smoke-induced damage that we have both from direct smoke as well as secondhand smoke. And the entire healthcare community in Oklahoma and the United States has worked to have smoke-free workplaces and public places. There are a lot of advantages for smoke-free policies. First of all, it helps support smokers who are trying to quit or cut back, and we know that that is a major effect on helping reduce smoke. We know that it reduces initiation of smoking among youth because they don't see it as much, and therefore reduces the addiction of youth. But having clean public air is very important. In fact, we also know that there are organizations that won't have meetings in cities that don't have a 100% Clean Air Act, and we do not have, I'll point to this in just a minute, we don't have 100% Clean Air Act in Oklahoma. But marijuana smoking in public places will in fact harm public health and send inconsistent messages, especially to young people. And somehow this slide got messed up. I apologize for that. But this is a slide of states that have 100% clean air. Those are the states in blue. States that don't have 100% clean air laws, those are the states in gray. But most of those states do allow public, other cities and other geographic areas and political areas to pass Clean Air Acts if they so desire. If you will notice, if you turn your head sideways, you notice that in this particular portion of the slide, the two states that are gray and also have no blue triangles or green circles in them are Oklahoma and Tennessee. If you were able to see the entire map, you would also see that Virginia also falls in that category. And that's because Oklahoma still has a lot of loopholes in our clean air laws. So in conclusion, in terms of patient safety, what we recommend is, first of all, accepting the fact that there is no medicinal role in smoking. That is, no legitimate medicine is ever delivered by smoke. So if this is medical marijuana, then we should keep the delivery methods of the drug consistent with that of other treatments. And then we really need to close the loopholes that we have in our clean air laws. This will help a lot with the issues that we've talked about. And specifically, we're talking about Titles 21 and 63. So we really need to have true smoke-free policies, and we need to extend these to all combustible and vaped tobacco and medical marijuana. And in the absence of that, we really need to protect minors from the harms of secondhand smoke by outlawing smoking in places not covered by the public places law, such as cars. Thank you.
Thank you, Dr. McCaffrey. At this time, I would like to recognize Deborah Billingsley. She is the Executive Director of the Oklahoma Pharmacist Association. You've done a good job up here. I'm used to working with Clayton Taylor and you guys, but you've done a good job. So thanks for coming up. And I guess it's Director Billingsley.
Director Billingsley.
All right, Director Billingsley, you are recognized for your presentation.
Thank you, Mr. Chairman and members of the committee. We do appreciate you allowing us to testify today. As stated, my name is Deborah Billingsley. I am not a pharmacist. I have a law degree, and I am the Executive Director of the Oklahoma Pharmacist Association. We represent the majority of the independent community pharmacists in the state, and we are not funded at all by big pharma, so I just wanted to clarify that. Today I also have with me two pharmacists to help answer questions if you have any pharmaceutical type drug issues, specific drug issues. Shonda Lassiter is with me, and she has pharmacies in Del City, Guthrie, and Lawton. And I also have Laura Cudd. She has pharmacies in Oklahoma City and Clayton. So why do pharmacists want to be involved in the dispensing of medical marijuana? Well, first and foremost, the pharmacists have the training. Right now, they have to get a doctorate to get out of pharmacy school. They learn about medicinal chemistry, pathophysiology, and pharmacotherapy. They have expertise, training, and knowledge to know how drugs are absorbed, distributed in the body, metabolized, and excreted. So we believe they're the best professional to advise and counsel patients to maximize desired effects and minimize adverse drug effects. So we do believe that the pharmacist is your best person in interpreting and evaluating medications. We also believe that we've had a few people say that this isn't taught, medical marijuana is not taught in pharmacy school, but I can assure you that there are a lot of new drugs that come out every day that are not taught in pharmacy school. And they do learn about them. They're required to get continuing education every year. So they have opportunities to learn about all the new drugs out there. And we do not believe that medical marijuana would be a problem. The other reason that we think that the pharmacist should be in the dispensary is that we think that they would be able to give better information. And I'm basing some of this on a research project that was just done in May of 2018. It was done in Denver, where a researcher posed as a pregnant woman. She called over 400 Colorado dispensaries. Now, they are not required to have pharmacists in their dispensaries, but she posed as a pregnant woman with morning sickness, and in 70% of the time, she was recommended marijuana, even though prior research shows that using pot during pregnancy may have adverse effects on the fetus. So, so we believe that a pharmacist would be better equipped to counsel patients. We're not the first state to have to deal with this, obviously, and there are other states that do have pharmacists involved. Arkansas now requires each marijuana dispensary to appoint a pharmacist consultant. Connecticut permits only a pharmacist to apply for and obtain a marijuana dispensary license. Connecticut was the first state, I believe, to allow pharmacists in the dispensaries. They have scheduled marijuana as a C2. I understand that there's some other states that have also scheduled marijuana on their state schedule as a C2. I know Oregon has. Connecticut is also a state that requires prescriptions of medical marijuana to be reported to the PMP. Minnesota also permits pharmacists, requires pharmacists to give final approval for the distribution of medical marijuana to a patient. New York requires a pharmacist to be on the premises and to supervise the activities within a marijuana dispensing facility whenever the facility is open or is in operation. Pennsylvania doesn't just require a pharmacist, but they require that it either be a physician or a pharmacist on site at all times during hours when a registered dispensary is open. So we don't have to reinvent the wheel. There's already plenty of information out there. It's working in those states, and we believe that dispensary pharmacists would provide the patient with important information about drug interactions and side effects. The other thing I wanted to share with you was that the Oklahoma Pharmacist Association, as I said, we have almost 500 independent pharmacies throughout the state. A lot of them, majority are in the rural areas, but we did poll them back in the fall, and we had a lot of discussion about medical marijuana. And it's probably not surprising, but 56.8 stated to us that they were going to vote yes to legalize medical marijuana. And they all had some concerns, but as you can see, that percentage is pretty close to what it was statewide. There were a few counties, obviously, that didn't have that, but we went along pretty much with the rest of the state on medical marijuana. 72.5% of the pharmacists did want to be involved in the dispensing. If it was truly going to be for medical purposes, they wanted to be involved. And so the reason I know that a lot of people have questioned then, why did you oppose State Question 788? Well, we believe that drug laws should be standardized. We believe that acetaminophen, it has more restrictions on it than the marijuana was going to have on it. We think that the drug laws should be uniform. We believe that patients in Oklahoma should know that wherever they go to get their drugs, especially scheduled drugs, that there's going to be a medical professional involved and that all of the same safety requirements are in place. So what is it that a pharmacist, what role would they be playing? Right now, these are the same roles that they're playing in a pharmacy, and they are the same things that you would see for scheduled drugs in any other state. But they're trained in HIPAA. They maintain confidentiality and privacy. They know how to properly label prescriptions. They know how to, they're educated on interactions. Cannabis is just like any other drug, and so there are going to be medications with drug interactions, side effects, and dosing considerations. And some of the information that I received showed that cannabis sometimes has interacts with statins and interacts with blood pressure medicines. And so it would be very helpful if a medical professional was the one doing checking for interactions. As with any other controlled substance, they're trained to conduct nightly and monthly audits. They know the state and federal guidelines. They are required to report discrepancies. They have to enact policies to ensure that there's no diversion of inventory. They are always prepared to help with state inspectors through unannounced inspections. And they're trained to maintain all of the records that are required regarding inventory, manifest, and pedigrees. And pedigrees is where you track the product from patient from the manufacturer to the end user. The pharmacists are trained to develop and maintain programs to monitor actual and potential adverse drug effects. They know how to maintain drugs. They know what conditions drugs are supposed to be maintained under, what the temperature controls should be. They know that they need to be aware of where the drug comes from so that they can verify safety, identity, strength, quality, and purity of the drugs. They're trained to develop and maintain drug recall procedures, which can be very involved, and make sure that they get those drugs off of out of the hands of the patient. They're also trained on handling products that are outdated, damaged, deteriorated, misbranded, or tainted. Some of the other misconceptions that I wanted to clear up was I've heard several people say that pharmacists would be jeopardizing their DEA permit. So I wanted to clarify. The DEA provides a license permit to individuals, to the physicians, the prescribers, and to mid-level practitioners. And they also provide certain businesses with a DEA permit. So that would be your pharmacies, your hospitals, your teaching institutions. The DEA permit can allow for Schedule I research, or for instance, the canine handlers, they typically will get a DEA license that allows them to have Schedule I drugs so that they can train drug dogs for law enforcement and other purposes as that. But pharmacies typically do not dispense Schedule I drugs. So at this point, there is no jeopardization of the pharmacist's DEA permit because they do not hold a permit. But as long as they're not dispensing from a pharmacy, I do not believe that there would be any issues. The other area of concern that we have is Oklahoma has gone through a lot of expense. They were one of the first states to create a PMP, and we fully believe that if medical marijuana is being used as medication, it is a scheduled drug. It needs to be in the PMP. Right now, under privacy rules, a pharmacist, a medical person, or their delegates can have full access because they are trained in HIPAA and protection of the information, the medical record. If for any reason that you all decide that you do not want a pharmacist to be involved, we would still recommend that the PMP be used. The OBN has advised me that they can create a limited access role that would allow a user to submit data but not have access to the patient records. And so if it's not a medical professional or a delegate of a medical professional, then we would recommend that they be given a limited access. But at this point, our recommendation is that a pharmacist be involved and that they have full access to the PMP, that data be entered so that medical professionals can truly provide help to their patient and see what their patient is taking. The whole purpose of it was to prevent abuse and to help the patient. So we hope that you continue using the PMP. Let's see. So in conclusion, I'm just going to recommend that that the order, that whatever you all do, that it be transmitted electronically. That is the direction that we're going on the other controlled substances, and so we would request that these also be submitted electronically. We're recommending that you require pharmacist oversight in dispensaries, and we are requiring entry of medical marijuana purchases into the PMP. And with that, I will hand this over to Dr. Beeman.
Thank you, Director Billingsley. Dr. Beeman, you are recognized.
Thank you, Mr. Chairman and members of the legislature. So I'm Jason Beeman. I am currently the chair of psychiatry at Oklahoma State University for Center for Health Sciences. I have to be very clear that I am not speaking on behalf of OSU or OSU CHS. I'm just here speaking in my role as a physician. I am representing the members of the Oklahoma Osteopathic Association and the Oklahoma Psychiatric Physicians Association. I am board certified in family medicine, psychiatry, forensic psychiatry, and addiction medicine. I hold a master's of pharmacology from the University of Florida and a master's in public health from Johns Hopkins University. I consider myself to be very well educated on the field of cannabis and medical cannabis because I've been researching it and reviewing the literature for the last several years. Last week, you guys had the opportunity to hear someone talk about the research and say that there's this narrative out there that there's no research in cannabis and that there's over 20,000 studies on PubMed. And I would agree with that, and I would inform you that I review every one of those studies every day. Every study that's released on PubMed that relates to cannabis, CBD, THC, or marijuana, I review those articles. Just to let you know, that was 8 today. It was about 6 yesterday, and really comes up to about 30 to 40 a week that I review, and then I read the ones that I feel like are important to public health and to the field of psychiatry. Most of those studies are population-level studies that demonstrate the harms and or benefits of marijuana. I will tell you that overwhelming majority of those studies are in the negative on the population consequences of marijuana. Another problem with the research as it stands is that the studies were done on marijuana. They didn't break them down into THC versus CBD until more recently. We're doing that, and we're seeing that a lot of the great benefits are from CBD at the expense of THC. It's kind of hard to have both high CBD and high THC levels. So if we're going to get all the benefit, then we're going to do that at the expense of THC. And as you consider potency levels, I would encourage you to consider that. So there are certain areas of significant health and safety concerns as it relates to patients, including potency, the intensity of use. Also, how is this going to affect women who are using this when they're pregnant? We just heard from our pharmacist that this is something that is of high concern. And if pregnant women are going to go into a dispensary, at least in Colorado, 70% of them were recommended to use marijuana. And we need to know what those consequences are. Also, I'm going to be talking about the topics of chronic pain and opioids. So one of the first things we have to talk about is potency and how we have the ability to significantly concentrate the THC levels. So currently, the average THC levels that are sold are 20.6% for flowers and almost 70% for extracts. And I just can't tell you as an addiction medicine doctor how alarming the number 70% is. In the 1960s, the levels were at 0.5%. In 2010, we were at 10%. Now we're almost double that on average, and we just keep finding ways to get higher and higher THC level contents. That's incredibly concerning, especially for the psychoactive components. We have these new extract techniques that are producing products of 75% or more. And as we do that, we're sacrificing the CBD, which is really, in my opinion, that's where a lot of the good benefits come from, is from the CBD. And so why does potency matter? Why am I worried about numbers like 75 or 80%? We know that high THC potency is associated with increased admission to first-time drug treatment, increased severity of marijuana dependence and addiction, increased risk and earlier onset of psychosis, including a 5-fold increase with daily use of high THC and low CBD in marijuana. And then also we believe that higher THC levels may explain a rise in emergency room visits involving marijuana use that has been seen in Colorado since they approved recreational marijuana. We know that the intensity is also increasing, so it's more potent and it's being used more often. Daily marijuana use is at the highest level since the 1980s. Daily or near daily use of marijuana for all ages is about 50% from what it was in 2002, when only 12% of the population consumed the drug daily or near daily. More than 2 in 5 marijuana users are daily or near daily users, and that's an important distinction. There's a big difference between the periodic marijuana user who's smoking on weekends and somebody who is using it daily or near daily. Those effects compound themselves. So between 1992 and 2014, the number of daily or near daily marijuana users grew by 770%. Marijuana users are 3 times as likely as drinkers to consume daily. So why are we worried about intensity? It has higher rates of addiction. And I'm going to talk a little bit more about that in a second. It also has a higher risk of schizophrenia and psychosis. I'll be speaking on that. Dependence and use of illicit drugs increases suicide attempts, depression, and less high school completion among high school students that do not use illicit drugs. Highly related to cigarette use and tobacco abuse, and keeping in mind that marijuana users are more likely to concurrently abuse tobacco. It's been associated with a cognitive decline, and then also it's been associated with injury. And there's substantial evidence between the association of marijuana and increased risk of being involved in a motor vehicle crash. And not only just marijuana, but the potency of the marijuana in those motor vehicle accidents is increasing. In states where marijuana use is legal, there's increased risk of overdose injuries. And among marijuana, cocaine, and heroin, only marijuana is associated with a significant increases in the number of emergency department visits. 62% increase when used in combination with other drugs, and 100% increase when used alone. So individuals who are using marijuana, and I would say probably at those high THC levels, are going to the emergency rooms more often. When we talk about neonatal exposure, marijuana used during the pregnancy is increasingly significant. We're learning a lot more and more about this, and as we have more longitudinal studies from states like Colorado, we'll be able to know even more. We do know that the highest rates are in the first trimester, and this is very important from a medical realm because this is when the brain is developing and when the other organs are developing. And as you just heard, nearly 70% of Colorado dispensaries recommended marijuana use to treat nausea in the first trimester. And so why do we care if it's being used in the first trimester? First of all, we know that it crosses the placenta, so we know that the babies are getting this chemical. It accumulates in fetal tissues, especially the brain. The way that marijuana is a compound, it goes into the brain and it deposits. That is associated with changes in the ECB system, so it's actually changing those cannabinoid receptors that are located in the brain. That change has been associated with increased risk-taking behavior, other neurodevelopmental deficits, and has been associated to demonstrate that kids who have this exposure are more likely to go to the neonatal ICU. It's important to talk about marijuana use and opioids, and this has been a large part of the narrative in the state of Oklahoma. I'm on the front line of the opioid epidemic, treating patients with this disorder every day. First thing I would tell you is that in the last 2 years, opioid prescribing in the state of Oklahoma has gone down by over 20%. So everybody likes to talk about how big of a problem it is, but I think it's really important to talk about all the great work that's being done by the state agencies in the academic institutions to decrease this opioid use. And to think that we need to, at this point, supplement marijuana to treat the opioid epidemic, I think is a misunderstanding of the current problem. To talk about the opioid epidemic in marijuana, we first have to talk about chronic pain. And there have been several studies that have demonstrated marijuana use does not affect chronic pain. Those studies are high quality and they're in national journals, and they're recent, including Lancet, which is the #2 medical journal in the world, just last month. So if we think that individuals are going to be able to take marijuana to treat their chronic pain instead of opioids, the scientific evidence doesn't show that. The next thing we assume is that individuals will stop taking opioids and then start using marijuana. But we have seen that not to be true from the other side. Patients right now that are taking opioids are also taking marijuana. So they're not just supplementing, they're using marijuana, they have access to it, they're taking it, and they may be taking it for chronic pain, but they haven't stopped taking their opioids. So there's no real reason to think that individuals will stop taking the opioids when they start getting the marijuana from a medical dispensary. And then I do want to spend some time on addiction and mental health. So when it comes to addiction, marijuana is an addictive substance, and there's little dispute among that in the medical and academic community. There are a lot of medicines that we use in medicine that are addicting. To prove that, marijuana activates the reward circuit. It increases the levels of dopamine in that pleasure center in the brain that causes pathways to be developed that make you want to use this substance again. And it doesn't happen in everybody, but it happens. And we can't deny that. There are some people that will become addicted through this medical marijuana practice. We know that 10% of users, 1 out of 10 people that use marijuana ever once in their life will become addicted. We know that if you're a daily user, that goes up to upwards of 50%. 1 out of 2 people who are daily users will become addicted. And probably even more concerning is that 1 out of 6 adolescents, so if they start smoking marijuana when they're an adolescent, will become addicted. So very alarming numbers from the addiction realm. I can diagnose cannabis dependence. It's an ICD-10 code. It's a DSM-5 code. I have diagnosed cannabis dependence. I've treated it. So to say that it doesn't exist is really, again, just a misunderstanding of the literature. I will tell you that the evidence regarding CBD is less convincing for addiction. So I would be more concerned at this mismatch of THC and CBD when it comes to addiction. When we talk about mental health, I've heard testimony and I've heard the narrative that this might be a save-all for all of our mental health problems, and I'm concerned that it would actually be the other way. Let's talk about depression. Marijuana is a depressant. And all of those symptoms that you have with depression, like low energy, fatigue, trouble sleeping, and trouble concentrating, marijuana would make worse. As a psychiatrist who treats depression every day, I would never recommend marijuana for the treatment of depression. There's also a concern for suicidality with marijuana because it's a disinhibiting substance. People are more impulsive and disinhibited when they use this, just like alcohol, so I would be concerned for an increased risk of suicide. Another condition that it's often considered for is anxiety. And the studies have shown that marijuana as a substance makes anxiety worse. It actually precipitates kind of an immediate anxious state and increases your heart rate by upwards of 20 points. So you become tachycardic, you have heart palpitations, and it can make your anxiety worse. I've heard a lot of concern for our veterans, and I think that that's an appropriate concern, and anything we can do to help veterans, I would absolutely be on board for. Marijuana is being studied in the veteran population for PTSD, and I'm very anxious and concerned to see what those results of that study are. I think that using marijuana for PTSD at this time is way early. I think we're probably a decade away from that. Also, in the state of Oklahoma, I have very high concerns for our veterans if they were to go through this medical marijuana practice, because the VA has said that if their patients test positive for marijuana, that they're at high risk for losing their VA disability benefits. Also, VA physicians are not allowed to prescribe or recommend this. And so there's a question of access for the veterans. Are they now going to have to enter into 2 different healthcare systems to get this? And by doing so, would they lose their benefits? It is often talked about as a treatment for insomnia. There was a high-quality study that was published within the last 6 months that was the first study to look at insomnia, but breaking it down by THC and CBD content. And it turns out that all the benefits for insomnia came from the higher CBD, and that actually as the THC content went up, you had more levels of insomnia. So marijuana actually makes insomnia worse, and we would not recommend that as a psychiatrist to help you sleep. And then absolutely most concerning from a mental health realm is schizophrenia. And I can stand here and tell you today that marijuana precipitates schizophrenia. The science on that is it's well-founded, it's long studied from many nations since the 1970s. We know that the correlation between schizophrenia and marijuana use is absolutely there, and few people would dispute that. I can't tell you that it causes schizophrenia, but I can tell you it precipitates it. I personally, as a psychiatrist who treats severe mental illness, have probably seen around 5,000 people with schizophrenia. I have only seen 2 that have never smoked marijuana. Now, I can't tell you that that's chicken or the egg. Were they smoking marijuana because they were hearing voices? Possibly. I can't tell you that they smoked it before, but I can tell you that out of the 5,000 or so that I've seen, only 2 have never smoked marijuana. We know that there is a condition outside of schizophrenia called cannabis-induced psychosis, where cannabis use actually precipitates a psychotic state. I've hospitalized people for this. Usually it's a prolonged hospitalization of 3 to 4 weeks as you wait for the marijuana to get out of their system. So from a mental health and addiction realm, I have a lot of concerns. So my recommendations would be, number 1, is THC levels should be limited to 12% or less. There's no medical studies that show that the medical benefits increase as you have higher levels of THC. And I have to tell you that 12% as a treater of brain illness, 12% is still incredibly alarming because all the studies that were done to show the benefit were done at levels of 5 to 8%. Number 2 is that we really have to be cautious in using this for patients under 25 because under 25 the brain is still developing. And all of those schizophrenia studies that I've read and that I talked to you about were all done in people less than the age of 25. The development of schizophrenia after the age of 25 is less. Number 3, patients should be assessed for addiction and mental health risk. When we use these medicines in the clinical setting, it's a risk-benefit analysis. At every patient contact, every point of visit, we're evaluating, is this medicine still worth the risk and the benefits? And we do that for Tylenol, we do that for Claritin, and we should definitely do that for marijuana. These patients should be assessed for any indication, at least on a monthly basis until they're stable and their dosage isn't changing, to see if they're developing addiction, to see if they're developing psychosis. If we're going to do that, the clinician has to have some sort of avenue to withdraw the use of marijuana in those patients. If someone is becoming psychotic by this, as a psychiatrist, I should have the ability to limit their access through legal means to marijuana like I would any other medication. And we do that all the time for opioids and benzodiazepines and other addictive substances. If we believe that you're becoming addicted, we try to limit your access. Number 4, physicians should be required to consult the PMP prior to issuing a recommendation. The PMP is a way for us to check for diversion and doctor shopping. And in Oklahoma, we're required to check it every 6 months before we write any controlled substance. And I personally believe that it's every physician's ethical responsibility to check it every time they prescribe a controlled substance. I can tell you of at least 5 patients in the state of Oklahoma that have died because physicians were not checking the PMP every single time. It's a controlled substance, it's addicting, there's concern for diversion, there's already a black market for it, so why would we not use the PMP? The PMP allows the physician to have more evidence to use in that decision of risk-benefit analysis. And then number 5 is that physician recommendations should include a prescription. Every time I write a prescription, I have to write dosage, instructions, duration of use, route of administration. And if this is a medicine, why would I not do that? If I write a prescription for Tylenol, I have to do that. Why would I not do it for marijuana? I have to know what my patient's taking. I have to have the ability to titrate it up or titrate it down. What if it's not working for their seizure disorder? Would I tell them to smoke more, but I don't really know what strain that they're smoking. What if they're developing psychosis? Would I tell them to smoke less if I don't know what they're smoking or ingesting? So I believe it's very important for physicians, if this is going to be a medical product in a medicine, that we should have the ability to treat it like every other medicine that we use. Thank you, and I'd like to turn it over now to Dr. Schaefer.
Thank you, Dr. Schaefer. You are recognized.
I'd like to thank the legislators, the committee chair, the public for being here for this important conversation. I'm humbled by following some of the people that we've talked about. My name is Scott Schaefer. I'm the director of the Oklahoma Center for Poison and Drug Information. I'd like to make clear that I'm here as a pharmacist, as a toxicologist. I'm not speaking for the University of Oklahoma, nor for the Poison Center. To start out with, I feel like I'd be remiss in my mission to make the world a safer place if I didn't ask everybody here to put the Poison Center number in their phones. So, and this goes for the people that are listening as well. If you text the word poison to 797979, you'll get a V card back. It goes straight into your contacts. We've got pharmacists and nurses that are answering the phones 24 hours a day. And we do answer calls about marijuana. And I feel like I'm here primarily to speak about children. Kids get into things. A 2-year-old is our bread and butter. They can and will get into any product that is in the home, outside the home, in the shop, in the shed. So I want to talk a little bit about things we might want to think about regarding children's access to medical marijuana. So our numbers of calls that we received in 2017 reported to the Oklahoma Poison Center actually were fairly low. I think there are a few reasons for that, not least of which is that parents and caregivers are somewhat reluctant to contact somebody who might be in a position to report them if their child gets into a product that is currently illegal. I can't tell you the number of times that we received calls where children truly were in danger, not from marijuana, but from heart medicines, from blood pressure medicines, from diabetes medicines. And parents are afraid to get their children treated when it's truly a life-threatening situation. I think that reluctance kind of follows through into our numbers that I'm presenting here. So in 2017, we received a total of 54 calls regarding pediatrics, and that goes up to age 17, who had gotten into a marijuana product of some type. The majority of those were in the 13 to 17-year-old age group. That's not surprising. We've got teens, adolescents who are experimenting with marijuana or maybe regular users of it, but the children getting into it. That was about 15% of our cases. Another thing that may impact the numbers of people who call the Poison Center is that calling the Poison Center is not mandatory. A lot of people don't know we exist. That's why I want our number in your phones. Physicians who are treating a person who is exposed to anything, if that physician feels comfortable calling us regarding the person treating a toxic exposure, it may not generate a call to the Poison Center. We're always on the mission to get people to have our number available and to call with any type of exposure. And I want to assure the public that there is no reporting of cases to the Department of Human Services or to anybody. We are interested in the health of the person who calls or the child who the caregiver is calling for. So I think it can be instructive to look at the experiences of other states who have adopted either medical and or recreational marijuana to get a feel for what's going on in those states after the adoption. Colorado is a good example. There's a lot of good information coming out of studies from Colorado. So after the legalization of marijuana in Colorado, trips to the emergency department for children, again, I'm talking about kids, doubled after the adoption of legalized recreational marijuana. It just makes sense. You've got more marijuana in the home, kids get into stuff, they imitate what adults do. Now, you know, a 2-year-old's not going to be lighting up a joint, but think about the edibles, stuff that might be attractive to children. You also need to think about the plant material. If you've got the flowers that people are smoking, kids will eat anything. I can't tell you the number of times that we get calls on children who have eaten cigarettes, entire cigarettes, got into the ashtray and eaten cigarette butts. In fact, that's one of the first things that we teach a new staff member when they come on. How many cigarettes would it take to generate potential, you know, we need to have this kid evaluated in an emergency department. How many cigarette butts? Kids will eat anything. So nearly 50% of those increased calls to the poison center in Colorado, the Rocky Mountain Poison Center, or I'm sorry, for the increase in the number of exposures in emergency department visits was due to infused edibles. Part of that is the form that they're in. Edibles come in a lot of different formulations. You can have them appear as candies, cookies, baked goods, a lot of different ways. And they generally are flavorful. Packaging is attractive to children, and therefore the kids get into them. Calls to the Rocky Mountain Poison Center, which covers not just Colorado, but several other states. Several other states contract their services out to the Rocky Mountain Poison Center, increased 500%, fivefold from 2009 to 2015. Again, that is due, in my opinion, strictly due to the increased availability in Colorado. So let's talk about what happens when a child gets into marijuana. It's not surprising that the primary effect that we see is drowsiness. Our bigger concern, however, is the level of that drowsiness. When a person gets drowsy, sleepy, and progresses on, we call it central nervous system depression. As the central nervous system gets depressed, a lot of other functions go along with that central nervous system depression. One of the things that we're concerned about is breathing. Now, do people die from not breathing after exposure to marijuana? No. Another concern that we might have, however, is in these 15% of children who are, or 14% of children in the study that I've got up on the screen that actually develop coma after exposure to marijuana, you have the risk for, at that point, respiratory depression and also loss of the gag reflex. So if the stomach contents, saliva, get down into the lungs, we have a risk for really severe pneumonia developing, which can be life-threatening. 14% of the kids in this study. 15% of those children were hospitalized in an intensive care unit, and I believe it was in this study, 80% were actually admitted to the emergency department. The interesting thing to observe from this study is that as THC increased, the likelihood of the coma increased. It was the higher concentration products that were causing the more severe reactions in the children. It kind of makes sense. I'd like to talk about 681 as it currently stands. And one of the things that really troubles me, and I haven't heard a lot of discussion about, is the transaction limits, or limit, if you will. In 681, you've got one transaction, a person can have 3 ounces of marijuana, the usable marijuana, 1 ounce of concentrated product, 6 seedlings, 6 mature plants, and 72 ounces of marijuana products. I'm assuming in that case that it's referring to the edibles. Think about 72 ounces. That's nearly the weight of a 5-pound sack of sugar. That's a lot of edibles. You can purchase all of those together in one transaction if you follow 681. There's no limitation on how often that can be done. Person can go in for either from dispensary to dispensary or day after day. Do people really need to purchase that much for their own personal use, or if they're a caregiver for the person for whom they're picking it up? I don't think so. Another thing that I have concerns about is that for those edible products that are going to be more attractive to children, there is no maximum concentration of THC specified. If something is being, a baked good, for example, has 10 milligrams of THC in it, yeah, I can see that. You can buy a bunch of cookies, for example, that have that in, or mints, or however it's packaged. It could be 40% THC. It could be 50% THC. It's not addressed whatsoever in 681. What I can see happening is very quickly a race to the bottom or the top, depending on how you look at it, to develop the most potent product to get out there for those edibles. We see it time and again in business. People want to distinguish themselves from the pack. And there are a certain amount of producers who are going to say, my product is stronger than the competitor's products. And, well, you know what? If an adult wants to purchase that, that's up to them. We know, however, especially with those edibles, that children are going to be getting into it. And remember that study that I mentioned. You have increased likelihood of intensive care admission and coma with the higher concentration products. Also might want to think about packaging as far as those edible products. Other states have adopted regulations where the product should not be attractive to children. Cartoon characters, for example. It's children, again, will get into anything. They see their parents following along or taking their medicine, and the child is going to want to emulate the parent. I am on the Medical Marijuana Food Safety Board. Wanted to talk briefly about that and some of the rules that we have suggested be adopted by the Oklahoma State Department of Health, the board of the Department of Health. It was a gratifying experience. We spent 3 full days hammering out the rules that went for ratification or adoption by the Board of Health. Had a wide variety of medical professionals, industry professionals. We had a medical marijuana patient on the board, and still do have all these people. And one of the things that we voted to pass on to the Board of Health is testing requirements for the edible products. I think it's really important. Things that we suggested that medical marijuana edibles be tested for include pesticides, solvents, heavy metals like arsenic, stuff that might be found in plants after growing, and bacterial and fungal contamination. All of these it's a distinct possibility they can show up in the plant, and during the extraction process of the active ingredients from a marijuana plant, you're going to be pulling out a lot of these contaminants as well. As the active ingredient is concentrated, you're going to be concentrating those pesticides, if they're present, the metals, anything else that's in there is going to be concentrated along with the active ingredient. Now, the board has not yet adopted our suggestions that we passed along, but one of the things that we were limited to was discussing only food products. My suggestion, I would encourage the legislature to look at testing for all medical marijuana products. not just the edibles. There's a couple of studies that came out that looked at medical marijuana products in California. And basically they were testing for bacterial and fungal contamination of dispensary available marijuana, the plant material as it was sold. And it was truly astonishing the wide variety of bacteria and fungus that was found in those products. And they weren't going to just one small area within the state. They were looking at a wide variety of dispensaries all across the state. We don't want that happening in Oklahoma. For one thing, we know that children are more susceptible to both these poisonous substances, the pesticides, the metals and so forth that might be in products, but also to a risk for infection. That our elderly are more susceptible to risk for infection, as well as the immunocompromised, a patient population that very well could be using medical marijuana. We need to think about testing for every single medical marijuana product that's going to make it to the market. Just briefly here, we've got an example of how pesticide would get into the product. It's important to note, and what I'm trying to establish with this slide is that since marijuana is a Schedule I substance, it is not legal on a federal level. There really are no EPA guidelines for pesticides to be used on marijuana plants. One of the references that we use at work is at the Poison Center is a manual that looks at various different pesticides that are used within different crops. And for every one of those pesticides where the fruit or the vegetable is going to make it to market for human consumption, there's a washout period. You can't apply this pesticide for X number of days or X number of weeks before you harvest it and get it out into the public's hands. There are no federal regulations or state regulations that discuss that with medical marijuana. And for that reason, I would encourage, again, looking for pesticides. Our pesticide thresholds that we recommended for the Food Safety Board were essentially none. We have to have that washout period to allow the pesticide to be removed from the plant. So my suggestions, make child-resistant packaging mandatory. It makes sense. Because we know that children will eat anything. We see it day in and day out. And it's not just the edibles that they're going to eat. It will be the flowers. It will be the concentrates. If a child can get into it, it will go into the mouth, it'll be swallowed, and we'll see some adverse effects. Use of a universal symbol so that we can figure out that just looking at it, yes, indeed, that is a medical marijuana product. Now, the Department of Health is developing a series of symbols that's going to come to the Food Safety Board. We're going to look at those, decide what would be the most appropriate, and it's going to be on all the edibles. I would encourage that that be adopted for all medical marijuana products. Specify a maximum concentration or a dose for the retail units for the various formulations, including the edibles, particularly the edibles. Remember, a person can buy that 72 ounces, and it can be incredibly powerful, highly concentrated. It's not addressed anywhere in 681. Opaque packaging to limit visibility of the product. And I'm thinking here, again, about children. Perfect example is the individual use laundry detergents, you know, the little packs that are very colorful. Kids see those. When the packaging was clear and there wasn't a whole lot of difficulty getting into it, kids would bite into those all the time. We saw plenty of cases of burns around the mouth, some of them further down in the gastrointestinal tract. Some children actually stopped breathing from it. Is that going to happen with medical marijuana? Probably not. But what did the industry do in response to children getting into those products? They put it in opaque packaging and put child-resistant tops on it. That, in my opinion, was a very effective way of cutting down on pediatric exposures to those laundry detergent pods. I would encourage the legislature to look at requiring opaque packaging. This might seem self-serving, but also poison center number on the outside of all retail packaging. If that medical marijuana product is going to make it into the hands of the patient, should they have an adverse effect, should their child get into it, we want to have a number where someone is going to be available 24 hours a day that can help them through. A question that I received from actually in the Food Safety Board, they were looking, we were talking about putting the poison center number on packaging for the edibles, which ultimately went in our recommendations, and one of the people said, well, you're going to refer everybody into the emergency department anyway. No, we don't. In fact, our goal, my charge to my staff is keep those people at home if we can do it safely. We follow up on all of our cases. Child gets into medical marijuana, we're going to evaluate the situation individually. We're going to follow up. If it looks like things are headed south, or if the child got into enough to really cause a problem, at that point, we're going to have emergency room physicians evaluate the patient. But we managed to keep 91% of our exposures at home, and I don't see that happening, or I don't see that changing with medical marijuana. Thank you.
Thank you for that presentation. At this time, I would recognize Director Croft. Now, by way of announcement, we have been in the presentation for about an hour and 25 minutes. So after this, we are going to take a break between the presentation and testing. So the members in the committee know and the public knows. But at this time, I would recognize Director Croft for your presentation.
Thank you, Chairman, and thank you for having me here today. I'm Julie Croft. I'm the Executive Director for the Center for Wellness and Recovery, Associate Professor in Rural Health, and the Director of the Master of Public Health Program at Oklahoma State University. I am here as an expert in substance use and public health, and solely representing my expertise as an individual and not of the institution that I work for, either OSU or OSU CHS. First, let me tell you, because we're doing a little bit of a paradigm shift from individual level to population level. So I'm talking about public health, which is our population level health, and what we do in public health is efficiently use our resources to improve quality of life, help children thrive, reduce human suffering, and a really good example of what we do in public health is seatbelts. So we know that there's a danger in being a passenger in a car or driving a car. We don't ask people to not get in cars. Instead, we mitigate the risks to individuals by asking everyone to wear seatbelts. So the recommendations and the thoughts that I bring to you today are related to seatbelts in that they will mitigate harms to the population. In general, public health has a return on investment for every dollar invested in public health. The state will see $14.30 back. So every dollar that you spend in prevention will come back to the state. In public health, we are not focused on genetics. We are focused on lifestyle and health behaviors, but the majority of what we're focused on are social factors because those influence health more than anything else. So the physical and social environment have huge impacts on what individual behaviors exist, the quality of the medical care, et cetera. So if you look at this diagram, 75% of health will be predicted by medical care and the physical and social environment. Here's where we distinguish. So patient health, which is what we've been hearing about so far today, focuses on individual patients. Public health focuses on whole populations. So we're asking the question, how can we achieve optimal health for Oklahomans? Medicine diagnoses, treats, and cares for individual patients. Public health seeks to prevent things from even getting to a diagnosis in the first place. If we're doing our job right, you don't know that we're there. We are totally invisible. You don't get sick in the first place. Individual patient health protects patients with clinical interventions. Our work protects the public with health education, doing research, and having evidence-based programs and policy. So what we know about youth substance use and substance use in general is that substance use is affected by two main things: availability, which is again going back to that physical and economic access, and perception of harm, which has to do with the norms or how we feel, how accepted we feel the substance use may be. We see perceptions of harm for marijuana decreasing across all age groups. This is why we're seeing sweeping legalization from state to state, whether that's for recreational or medicinal use. Now, the two currently legal drugs nationally, tobacco and alcohol, are the most costly to society, and that is not because of the substance itself, but because of the number of people who use. When you have 70% of Americans using alcohol in the past month, you will see more harms related to alcohol because more people use. As perceptions of harm decrease, daily use increases. If it is perceived to be something that is not harmful, people do it. So we're seeing that currently perceived risk is dropping for marijuana in general, and use for 12th graders is increasing, daily use. So what's going on? Because the other thing that we're seeing among youth is that their smoking is decreasing, their alcohol use is decreasing. The only thing that is not decreasing, that is not sharply declining, is marijuana use. And in legalized states, it is quite a bit higher than in other states. And what we're seeing in particular are effects on youth who are pregnant teens. We're seeing youth using daily or near daily, and an increase in youth smokers. Now, nearly 52% of youth tobacco smokers are also currently using marijuana, compared to those 5% who do not smoke marijuana. Availability is a key piece of this. So availability is higher in states that have either recreational or medical marijuana. This chart, and I hope that you can see the colors in the audience, really clearly demonstrates that if you have medical legalization or recreational legalization, there's more past month use among 12 to 17-year-old youth. Oklahoma is currently at 5.4%. We're in the bottom in the zone that's all gray. We anticipate that those changes we will move up into the 7 to 9% range where you see most medical legalized. And if there aren't appropriate controls put on the use of medical marijuana, we may look more like the recreational states, which were upwards of 11%. So what I want to talk about to start is what first exposure to medical marijuana is going to look like. This is an advertising campaign from California, which is recreationally legal as of January 1st, 2018, but has had medical marijuana for over 20 years. This company started as a medical marijuana company, the MedMen. This is a social norms campaign. This is normalizing marijuana use, saying your local police officer, your coach, your local drag queen, your entrepreneur at the bakery shop, your designer, all of them use. This sends a message to youth that use is very normal and everyone uses. This is not medically relevant. So we have this first exposure through ads. These ads can take many different forms. So it could be a banner ad like the one we just saw. It could be sign spinners with price promotions. It could be signs that look very much like our political ads sticking in lawns. These ads exist because advertising works. The alcohol industry continues to spend money on advertising. Tobacco has been sharply restricted in their use of advertising because it affects youth more than anyone else. Alcohol industry spends $4 billion a year on ads. Pharmaceutical industry spends money on ads. In either case, we know that advertising drives use behavior. We have billboard ads that are going up all over Los Angeles and have been, and Los Angeles is now considering local restrictions on use of billboards. And you'll see, again, there's the MedMen again here. So these are medicinal advertisements. Shop, it's legal. Legal cannabis, just minutes away with all of their locations. Youth see these ads. If they are on trucks, they are on your roads, they could be in front of your school. They could just park there. These ads can move, and that's especially problematic. According to RAND, kids who saw an ad for legal marijuana were more likely to report marijuana use within a year, and they had stronger intentions to use in the future. This is a city bus covered with a medical marijuana ad. Ads lack context for proper medical use and harms for developmental periods. This is a building wrapped in MedMen marijuana ads. We continue to see restrictions in how alcohol and tobacco are allowed to advertise. It is really important to consider how we allow marijuana advertising to start from the beginning. Youth view more ads for beer, 45% more ads for beer than those of legal drinking age. Youth view 27% more liquor ads than those of legal drinking age. Despite our restrictions on advertising, youth see this more than the people who would need it or need to have access to it. Another way of advertising, which relates to access, is coupons, economic access. Low price equals more access. In Washington State, they were handing out coupons for free cannabis to get people in the door. Bud is treated as a loss leader. It is what gets you in the door to the dispensary so that they can sell you more expensive products and upsell you. Should our medicines be buy one, get one free, buy one, get one 50% off? Should they be free overall? What other medicines do we have coupons like this for to the whole population? So from a public health perspective, we use price as a control to access. We know that low price equals access for youth. The lower the price, the more youth can afford to use. When we increase taxation on tobacco, youth use of tobacco products decreases. In order to create barriers to use for youth, we recommend price restrictions, and likely because as THC increases, there are more harms associated with use, really considering taxation that's a differential dependent on percent THC content. So the question becomes, what do youth know about marijuana? Before they see an ad, what might they know? 60% of Oklahoma youth have never even had a conversation with their parent about drug use in the last year. There's no requirement in our schools that we educate our youth about drugs, including marijuana. Exposure to marijuana marketing is prevalent among adolescents and is significantly associated with their use. And this quote is from Bo Kilmer. If you don't know his name, he is the one who is streamlining legalization in Canada and helping them set up their policies. He has helped in Washington State, he has helped in Colorado, he is objective, and his quote reads thus: research suggests that roughly 80% of marijuana expenditures in the United States are made by 20% of the users. These are heavy users who report using marijuana on a daily or near daily basis. If profit-maximizing firm wants to make serious money in the marijuana market, they will have to focus on creating and maintaining a large stock of heavy users. There are also concerns that for-profit industry and lobbyists will fight against regulation and taxation. I want to add to this a note of caution, which is needed when we allow education to be conducted by individuals with profit motive. In 2007, Purdue Pharmaceuticals pled guilty for misinformation about oxytocin. They said that it was non-addictive. They told physicians it was non-addictive. If we allow industry to be the only one educating our youth, we will get into another epidemic. What does physical access look like? Should we restrict or think about what the opening to a dispensary looks like? Should consider making it less attractive to youth. If you pull up just about any image of a dispensary, there's typically some advertising about the doctor being in. This is why there are recommendations from other members here today saying that perhaps physicians should not be at the dispensary, because it's viewed as problematic when the physician stands to make a profit when they own the dispensary that they are in. They have a motivation to make a diagnosis that allows the purchase. The question often comes up, what are other states doing? Other states regulate dispensaries. There are only 3 states that do not have any regulations on dispensaries. 64% of states restrict outlet density. 75% restrict dispensary locations. 71% permit local zoning. 89% are regulating product supply sources, and 43% limit stock amounts. As you look at this table and you see that there's some check marks in some spots and not in others, this is what makes it extremely challenging from a public health perspective to say, this is the set of policies that works, because every state is rolling out their policies differently. There's no oversight from the Fed, and it makes it very challenging to actually pick out what is what. And in all, because some states do and some states don't, it washes out effects from a research perspective. So one of the things that get regulated are outlet density. I know Colorado is currently recreational, but there are some lessons to be learned from outlet density regardless. Just as with alcohol outlet density, we see a similar role with dispensary outlets, and both of these are associated with violent crime. And these crimes are not at the dispensary location, they're in the neighborhood surrounding the dispensary. So if a dispensary goes in a quarter of a mile from my house, violent crime will increase in my neighborhood. As a citizen, I would want a voice in that. We currently have nothing in our policies. There's nothing in 788 that's addressing anything that I'm speaking about today, which is why I'm bringing it up. It is all on the table. The addition of dispensaries increases marijuana hospitalizations. It increases use. They're disproportionately cited for perhaps giving or distributing without proper documentation. And it also plays a role in advertising exposure, because as you saw on the front of the one dispensary, there are plenty of ads. There's one noted location in Colorado called the Green Mile along Broadway Avenue that has more medical dispensaries than Starbucks and McDonald's combined. I also want to talk about physical access in co-location of sales and where, how things are being used. So community events should be regulated. We should be aware of what is being sold so that there is not confusion between products. Tastings at community events are particularly concerning. There's no restriction currently on who could be licensed to be a dispensary and what else could be sold there. So you could have a convenience store licensed as a dispensary selling edibles next to other candies. This is problematic. This also goes back to the packaging issues. Obviously, there would be a price difference between these products. So from a youth attractiveness situation, I want to tell a brief story about blue ketchup. So there was a point in time where Heinz wanted to do something special and really appeal to kids. And so they released ketchups in lots of different colors. And what pulled best in their test kitchen was blue ketchup. So they put it on the shelves, and it didn't sell. And it didn't sell because mom and dad ultimately were making the decision on who was buying the ketchup. And for adults, blue is not an edible color. But if you're under 10 years old, blue is a very edible color and very attractive. So this goes back to what Scott's recommendations were in packaging. If you can see brightly colored candies, and you see these candies all include the color blue, it would be more attractive to youth. So if we can package medicines as medicines, then we can protect our youth. Again, an image where you could tell that things could be easily confused if they were on the same shelf. So co-location of sales is a difficult thing, and it becomes difficult to distinguish medical products from other products that may be sold in the same location. So overall, I have a number of recommendations. There are 8 in total, bear with me. First is to develop public information campaign to clarify the law, highlight risks, promote quitting or treatments, just as we do with other legal substances. Consistent and credible messages should be developed by public health professionals not affiliated with commercial interests. Regulate advertising of commercial marijuana to prohibit false or misleading statements, prohibit advertisements that target or induce people under 21, prohibit advertising in public transit or property, prohibit outdoor advertising, and limit retail signage on outdoor displays. Third, marijuana and marijuana products should not be in forms that target or attract children. Fourth, discount-free or other product promotions or inducements should not be allowed. 5, if the potency and/or intoxicating products are allowed, differential tax or pricing structure should be used to set higher prices on more harmful products. 6, dispensaries should be limited in number, not located near places where children frequent, and restricted for density. A system of public notification should be required. 7, dispensaries should not sell products other than medical marijuana and should not be co-located with other businesses. Marijuana sales or sampling should not be allowed off-premise, i.e. in community events. And 8, marijuana should be secured behind the counter, so no self-service machines or displays, and only licensed adult patients or caregivers are allowed to enter those dispensaries. I do want to mention that I have focused on advertising and dispensaries today. We have not discussed at all home grow, and it's a major source of youth access and diversion. This is a concern that should be discussed by this body at a later point in time. Thank you very much.
Thank you very much. Members, we have been going pretty steady for just under 2 hours. We are going to take a break. I'm going to bring everybody back at, let's say, 11:10. That gives you 13 minutes. Come back at 11:10. Thank you. All right, members, presenters, here's the way we're going to do this. Keep your seats for purposes of answering questions. What I would like for you to do is to say who you are before you answer, because there are people listening. I am going to ask you to keep your answers brief and to the question. We've had a very long presentation. We want to get to as many questions as we can. So answer the question as succinctly as possible so we can move on to questions for members. I know many of them have a lot of questions. Members, I'm going to ask you, you can direct your questions to the panel as a whole, or you can direct your questions to an individual presenter. Dr. Househair, I'm going to have you kind of be the, for lack of a better word, the moderator as things need to occur among the presenters. And if you would like to be recognized, I have already started a list. That was weird. And that's all right. So I'm going to go ahead and start off. This was just in order that people have asked to be recognized. Representative Fettgetter, you are recognized for a question.
Thank you, Mr. Chairman. Thank you all for coming and giving your presentation today. And, you know, I just have some questions that I need to get answered. But right out of the gate, I just got to be honest and tell you, I'm a little frustrated because what we just heard for 2 hours was exactly what our constituents were upset about over the rules that were coming down from the Department of Health. And, you know, we had State Question 788 was on the ballot. So my first question, and it was voted on by the people, and people are frustrated about the very conversations we just heard. And let me say this, I agree that if it's medical marijuana, let's make it medical marijuana, not recreational. I've always said that. But in my position, we have a law that's been voted on by the people. So my first question is, what have you been doing up to this point, or up to the point of passage, to work with the grassroots movement to open up and have these conversations? And anybody is welcome to answer that question.
Am I on?
Yeah, don't have to, you don't, yeah, so for presenters, you don't have to push the microphone. It is always on. And by the way, you do not have to push the microphone. It is always on. So if you are talking, it is on. Right.
Thank you. This is Jean Househair. Thank you for the question. So as I understand it, you're wondering what we've done with grassroots. I know personally, prior to the vote, sir, I was invited by the Yes people to several forums around the state of Oklahoma, and I attended those. I had conversations with people in the audience. I had, ground people. I've had a lot of conversations with my own patient base. I've had a lot of conversations. I've had emails, et cetera. So personally, I know I've done that. I can't speak for other panelists or other physicians here, but I can speak for myself. And those capacities were there. And so we started to have conversations, just kind of like today. And conversations are where things start and ideas start. So to say that we haven't been, or imply that, if that's what you're doing, haven't, we have. We really have. I've asked my patients a lot. In fact, they came in and a lot of them thought that because it said medical prior to the vote, they somehow thought that we had crafted the 788, and I hadn't realized that their perspective was that. And so I'm the one that kind of brought that forward on July 9th to the media. And it's just because of honest conversations, again, with a lot of different patients. I'm an ophthalmologist, so certainly I take care of glaucoma. And so that's the reason a lot of my patients would ask what they asked. I hope that answers your question, and I would jump in and anybody else.
Yeah, I would just say that, we are always involved and as open as we can be, but the way that the people vote doesn't change the dangers and the THC content. So if they want the high levels, that's certainly their vote, but it doesn't change the science at what the high levels do. And I'm just here today to try to educate you at what those high levels do so that you guys can make the best decision. Certainly, you have to weigh the will of the people versus the information you've heard today. And I don't envy you. I represent the great responsibility of that task.
Thank you. And there was no implication. This has been a very awkward situation. And could I get a follow-up?
For a follow-up.
I'm just curious if you could give me what percentage of doctors do you believe physicians will not participate in recommending medical marijuana?
This is, again, Jean Hauser speaking, and I'm not sure that we know that answer right now, and it might be appropriate for us to consider surveying that. But we are concerned because, again, we are having conversations with our colleagues, and in those conversations, there's a lot of uneasiness for all the reasons that you just heard, and we would like to help ease some of that. And it's not just physicians, it's a lot of different providers who also have conversations like we had today with patients. And so we need to have those conversations. Those are very important, but we might need to also survey moving forward. And we haven't really asked that question.
You get one more follow-up?
One more follow-up.
Thank you. So in the presentation, it was stated that in the safety and standards of care portion, relief for terminal illness expected to live less than 1 year. I'm curious, what does define the word relief for me. What are we talking about specifically?
I think relief means if you've been around someone that's going through terminal illness from whatever source, let's just say, for example, cancer. Sometimes that's a very painful disease. Sometimes they have no appetite. Sometimes they are on treatments that cause problems or side effects that are very adverse, and maybe nausea, vomiting. Maybe food just tastes terrible to them. It's just a whole host of things in that particular ailment or group of ailments that I was referring to. And so I guess I was just simply trying to define what I meant by end of life. You're right, we don't always know when we know someone is terminal with an illness, we don't know if it's going to be tomorrow or if it's going to be a year or 2 years. But we know most assuredly that certain ailments are going to have a very short span.
Sure. Mr. Chairman, may I have a little leniency? One more quick one.
You can have one more. Nobody else wants to ask questions. Don't worry about it.
Okay, I apologize.
You can have one more.
So when we talk about pain particularly, or nausea, those types of things, why would we only, under those standards, want to treat terminally ill? I mean, why wouldn't we want to treat anybody that has pain problems if this is a potential remedy?
Yeah, so I think when you're talking about pain, I think there's two discussions to be had. One is acute versus chronic pain. In the studies I cited, the huge Lancet study was specifically in chronic pain, which for lack of a better definition is somebody who is going to need treatment on an ongoing basis. So marijuana has been studied in that it's been found to be ineffective. Also, opioids have been studied in that and it has been found to be ineffective. Which is a huge paradigm shift that we're given all these opioids. Oklahoma probably at this point more than any other state in the country for a condition that really the evidence isn't there. The conversations regarding that are very similar to what we're having today. We were having with opioids in the medical community 20 years ago. So you have to establish acute versus chronic pain, and a lot of the cancer pain is more of the acute nature, due to the all of a sudden metastasis to the bones, the fractures of the bones. It's not that chronic pain that we're talking about. The other thing is risk versus benefit. If someone has terminal cancer, then our concern for addiction is minimized. Our concern for brain trouble and psychosis and all of that is minimized. So really it's a risk-benefit analysis that physicians have to make every day at every time.
Thank you. I have like 500 more questions, but I'm done.
Yeah. Recognize Representative West for a question.
Thank you, Mr. Chairman. Thank you all for coming today. My question's for Dr. Beeman, and I value your opinion. I appreciate the work you do with mental health. Most people know I'm very passionate about mental health. My wife's a therapist. We're both veterans, and so I've seen the stigma associated with mental health and PTSD, that type of stuff. You know, how can it adversely affect veterans specifically? I don't want to misquote you, but you're talking about you said you feel there's evidence that shows that medical marijuana does not, it's not beneficial for anxiety, depression, but there was maybe some evidence with PTSD, but you thought we were maybe 10 years out before, you know, that could be a viable way to treat it. Have you talked with, you know, through your research, any of the physicians in the states where they may treat PTSD with medical marijuana? Have you talked to those?
I've not had any personal discussions with the physicians, specifically at the VAs in other states where they may be using that.
Have you looked in, just personally, have you looked at, you know, treating PTSD with it, or the?
Yeah, absolutely, absolutely. And I think that my personal opinion is that if we're going to use marijuana in a mental illness, it's probably going to be in PTSD. I'm very, very anxiously awaiting the results of the studies that are being done in the veterans population. One of my biggest concerns with those studies, but also with all marijuana studies, is it the THC or is it the CBD? Because you can't just study marijuana, because what does that mean? And what is the THC content and what is the CBD content? So really, I think that the anxiolytic properties of marijuana are going to be coming from the CBD, and I think the studies are starting to show that out. And when I say that it's not beneficial for anxiety and that it causes anxiety, there is this, and it's usually associated in naive users or people who all of a sudden take a strain that they're not used to taking. They get this intense anxiety, kind of paranoia, adverse reaction. It doesn't happen every time. It doesn't happen to every person, but it's there. And because of that, I would not want to use it for anyone who has anxiety, specifically PTSD and veterans.
Okay, thank you. Thank you, Mr. Chair.
Thank you. Senator Daniels, you are recognized for a question.
Thank you, Mr. Chairman. I have three. First, could somebody address the use or benefit of medical marijuana with glaucoma? I know we mentioned some conditions at the beginning, but I know I've read something about that. Could somebody speak to that, please?
Leader Eccles, Dr. Hausherr speaking. Would I be able to call upon my colleague, Dr. Ben Harvey, who's a glaucoma specialist?
That'd be fine.
And also president of the Oklahoma Academy of Ophthalmology.
And what's his name again?
Dr. Ben Harvey,
Dr. Ben-
Harvey.
Dr.
Ben
Van
Harvey.
You're recognized.
Thank you. Thank you, Gene. Thank you for the question. I am the president of the Oklahoma Academy of Ophthalmology. I am a glaucoma specialist. I did my fellowship training at Bascom Palmer Eye Institute. And I am speaking on behalf of the Oklahoma Academy of Ophthalmology. Now, the role of marijuana in glaucoma has been studied since the 70s. For those that don't know, glaucoma is one of the leading causes of irreversible blindness in the world. In the United States, it's the #1 cause of irreversible blindness among African Americans. Now, marijuana's ability to lower intraocular pressure, which is what we use to treat glaucoma, has been established. The effects are only about 25%. What is lesser well known is that it only lasts for about 3 to 4 hours. Glaucoma is a chronic disease for which there is no cure. We've talked about the deleterious effects of glaucoma leading to blindness. What we haven't talked about is how glaucoma is a multifactorial disease. The only thing we know that we can modify is intraocular pressure, but there are other things that work with glaucoma. We know the use of marijuana lowers blood pressure. We know that lowering blood pressure in people with glaucoma can actually worsen the disease. It decreases the perfusion of blood cell to the optic nerve and can make the disease worse. Dr. Beeman talked about the problems of using marijuana for an extended period of time and at frequent dosages. You'd have to smoke or ingest marijuana about every 3 hours or 6 to 10 times a day. Now, I give you a variation of that because tolerance develops. There's studies that have shown that in the majority of patients who have used it over 9 months, the pressure-lowering effect of marijuana disappears. There's also an issue with compliance. The more complicated we make any drug regimen, the more likely compliance will not be upheld. We know that one of the major causes of blindness in glaucoma is noncompliance. So to have something that lowers the pressure only for about 3 to 4 hours, that has to be used 6 to 10 times a day, around the clock, mind you. So you would have to set your alarm every 3 hours to get up and take it, would overall be deleterious. In addition, its effect of lowering the blood pressure, its other effects on emphysema like lung changes, connection with cancer, and all the other adverse reactions that we have seen with this. So for this reason, the Oklahoma Academy of Ophthalmology, the American Academy of Ophthalmology, the American Glaucoma Society, the National Eye Institute have all said that there is no evidence, and we do not recommend marijuana in the treatment of glaucoma. Thank
For
you.
follow-up?
Yes, thank you. On a different topic. You know, we do read that people trying to quit smoking, that vaping can be an effective way to help people reduce their dependence on cigarettes and the damaging properties that are introduced to their system through the smoke itself. But you still included vaping on your list. So can you enlighten me there, please, Doctor?
Yes. This is Bob McCaffrey. Excuse me. First of all, I don't want to, I'm sorry, I have something in my throat here.
I didn't mean to choke you up.
Right. first of all, I don't want my comments to be confused with the fact that I am proposing vaping of nicotine being the same thing as vaping of marijuana. They are different. Now, they actually have commercial vaping devices for marijuana, specifically designed for marijuana. The one I'm familiar with is called PAX. In fact, I actually originally had a slide showing the PAX device, which looks like a Juul. If you're familiar with Juuling for vaping nicotine, it's the most popular thing in high school students right now. It's taken over the vaping market for high school students, but they look like little thumb drives, basically. And they have devices like this for marijuana. But because I know that there are people who use marijuana for medical reasons who say that they need the acute absorption and effect from the marijuana, and they say the only way they can get that is through smoking. That's why I was saying that there are safer ways to have that rapid absorption of marijuana other than smoking, which I think is inappropriate for a medical reason. So there are devices that you can use that give you the same rapid absorption of the marijuana through the lungs. Does that help?
You have a follow-up, Senator?
Thank you.
For follow-up?
Excuse me.
Well, yes, I recall you saying that, but again, that's something different than using the vaporizing, than being able to inhale the droplets or
from something like a medical vaporizer you're talking about, like you might use.
No, I'm just not making myself clear. I just saw vaping up there on your list of do not do this, and I was wondering though if you were using medical marijuana in a smokable form, would that not be a less damaging way to deliver the product? But you don't believe that's the case.
I think that absorbing it through a vapor that doesn't contain the particulates of smoke is a better way to deliver it, is a much safer way to deliver it. I think it's the products of the smoke, the particles, and all the substances that you saw on my list that are the most damaging aspect of smoking, and I think that that's inappropriate from a medical delivery system.
Scott Schaefer. I'd also like to point out that delivery of a drug through the lungs are very well, have a great deal of vasculature, a lot of blood supply to it, and so delivery of a drug to the bloodstream across the lungs is very efficient, very rapid. For that reason, I mean, think about smokers. That nicotine goes to the brain right away, and that is reinforcing for smoking. With vaping of cannabis-based products, it's going to be a very efficient method of delivering either the THC, the cannabidiol, whatever other product or whatever other compounds are in that product to the bloodstream. If a product is a medical marijuana product is eaten, the absorption can be very erratic. It can vary from person to person how much of that chemical compound actually gets into the bloodstream, and it's delayed significantly before the effects are seen. It can be 3 to 4 hours, whereas if something is inhaled, it gets into the bloodstream immediately. Another consideration is that when a drug or a compound is delivered to the lungs, it gets a pass through the body before it actually hits the liver and starts becoming detoxified. If you swallow something and it's absorbed into the bloodstream, the first place it's headed for the liver is for the liver, and so the liver starts the detoxification process or the inactivation process of that active ingredient.
Senator Yak, you are recognized for a question.
Thank you, Mr. Chairman, and this is kind of following up on that, so I appreciate that. One of y'all showed a slide. I think there was 5 conditions that were studies that showed there were some positive results. I'm curious, in those studies, was the type of delivery, was it differentiated between whether it's smokable or some other form of delivery? Was it better in some form than the other?
Jean Hauser speaking. Were you talking about the national academies that I referenced, or are you talking about a particular, which slide were you talking about?
I think it was a slide that listed 5 different conditions that I think it was one of your
Oh,
slides.
and you're asking where that came from?
The type of delivery systems that showed those positive benefits.
It was variable. That's exactly the problem with this. It's variable on the type, the patient population. That's exactly the problem with trying to, you can't compare an apple with an apple with an apple with an apple, apple, orange, cherry, carrot, because it's not uniform. The studies are not uniform. They're variable on dosing, on what's used. It all comes out of University of Mississippi, but the populations, and if they do inhale, which is what Dr. McCaffrey was talking about, people inhale differently, don't they? And I'll let Dr. McCaffrey jump in on that one. Excuse me just a second.
Yeah, no, I think I can't add anything more to that because the studies are so different in their design and in the way that they deliver medication. And as Dr. Hauser said, for people who are inhaling it, what we call the topography of smoking is very different. For example, most people, when they smoke marijuana, inhale very, very deeply. In some of the studies, if you're giving a more controlled, in animal studies, if you give a more controlled delivery, inhaled delivery of the marijuana, it's probably not the same smoking as somebody who is, as a human being, smoking the marijuana. And in fact, it's interesting that, well, actually what I was going to go into does not answer your question, so I think I'll stop there. But the design is very different of all the studies.
Senator, for a follow-up?
One follow-up. Thank you, Mr. Chairman. Kind of on that line, so as far as infused edibles, is there any medical reason that they're necessary or better than any other type of way that you can take the drug?
Yeah, I would say that all of the evidence is the delivery system has been taken out of it because it ends up with the amount of the THC, CBD, and the other cannabinoids that end up in your system. So as far as I know, there would be no medical reason to do an infused edible versus smoking versus just a regular edible, a tea. You're getting the same chemicals into your bloodstream, and that's where the biological activity takes place.
Senator Paxton, you are recognized for a question.
Thank you, Mr. Chairman. Dr. Beeman, this probably was more directed towards you. I have some constituents I was visiting with last week, and the discussion was in a comparison between alcohol use and marijuana use, especially in the younger ages. And this group I was talking to is, for the most part, a pro-recreational marijuana group. Mm-hmm. Their argument is that marijuana should not be regulated any more than alcohol is regulated. And then they were comparing things like the marijuana user would be more relaxed and content, whereas the alcohol user might be more aggressive. Could you address that a little bit and just kind of explain not just the behavior side, but how it would affect the body of, say, you mentioned people under 25?
Yeah, sure. And so Jason Beeman here, I appreciate the opportunity. And that's probably one of the most common comments that I get. And so I would make a couple of different distinctions. At no time in history that I'm aware of has anyone asked us to prescribe alcohol. And so right off the bat, it's apples and oranges. I would never recommend alcohol except for alcohol withdrawal in limited situations where I did not have access to all the other medicines. So it's recreational. And my comments, and I think a lot of our concerns would be different if we were talking about recreational marijuana versus medical marijuana. So as far as the behaviors, and I think alcohol and marijuana are both unsafe in adolescents, and I would never recommend that they use. I would absolutely never recommend an adolescent use marijuana because alcohol doesn't cause the significant brain changes that we see. It doesn't precipitate schizophrenia or psychosis like marijuana does. I don't know that there's anything more damaging to the developing brain that we see in adolescents up till the age of 25 than marijuana, except for maybe methamphetamine. Did that answer your question?
Yes, it did. Thank you. For a follow-up? No. Representative Bush, you are recognized for a question.
Thank you, Mr. Chairman, and thank you all for being here today. Very informative. I have two questions, and I believe they're for the pharmacy folks. So, first of all, in your presentation, you referred to the survey that you did where the numbers matched pretty much what the voters did? So the 56.8%, which that voted yes for that, very close to our numbers. What was your sampling size?
It was just my members, and so it would have been around, because that's who I would be asking, it was for, to find out whether they were interested in this topic. And so it was around 800.
Okay, thank you. And for follow-up?
For follow-up.
Or second question, if you will. Were there any studies that demonstrate medical indications for the use of THC?
Yeah, Jason Beeman, as far as I know, THC specifically as a compound is mostly studied in seizures. And my understanding is that it's kind of a progression, that at lower THC levels it's more effective, but then at higher THC levels it is actually epileptogenic, and that it causes seizures. Yeah, that's a fancy word. I can't hardly pronounce it myself, but that it actually induces seizures. And I don't want to get strong into the synthetic marijuana discussion, but synthetic marijuana like Spice or K2 that you may have heard of, that has the same THC compound. It's tweaked in a little different way, but it activates that receptor, and it does so much, much more powerful and binds, and it doesn't let go. But one of the most common adverse effects we see from the synthetic marijuanas that are illicitly manufactured is seizures. So we're very concerned about seizures as the THC level increases. Other than that, I can't think of any of the specific medical benefits of THC as opposed to the CBD. We think that a lot of the benefits, especially as the calming effect that was mentioned, is more CBD dependent outside of, I think, emesis. Yeah, emesis, nausea. So nausea and vomiting would be a THC specific action.
If I could just interject, this is Dr. Househair again speaking a little bit about your question as well. Just in conversation with my patient base, because I like to do that, a lot of them who illegally have using prior to this, and were upfront with me about that, they were under the false assumption that unless they were high on the THC, and I tried to teach them that the H in the middle of that was for high, that if they weren't high, then it wasn't medicinal, and that really isn't true. So that's something that I found, and they don't know each other, but they all kind of had that sort of idea, and that's something that's, I don't know where that idea came about, but that is not true. And so I think that a little bit intertwines a little bit into what you were talking about.
Yes, thank you very much.
For follow-up?
I'm good, thanks.
Representative Dolans, you are recognized for a question.
Thank you, Mr. Chairman. This question is for Ms. Croft. You mentioned in your presentation that if a dispensary goes in a quarter mile from my house, and violent crime will also increase in my neighborhood. I did a quick fact check, and it came back as false. So can you please elaborate on the data that led you to that conclusion?
A peer-reviewed study by Dr. Bridget Freesteiler at the OSU in Ohio is the author of 2 density studies. That one is the one that I was referencing here, and that was that outlet density influences crime in the surrounding neighborhood.
For a follow-up?
Can you also elaborate on, you said that different parts of a neighborhood or income determine density levels. Can you expand on that a little bit, please?
I don't believe that I did say that. Can you remind me or cue me in a little bit more?
I'll follow up afterwards when I can.
For a follow-up.
And this question goes to Ms. Billingsley. You mentioned that pharmacists are not learning about marijuana in pharmacy school, so they're educating themselves. Can you please elaborate on this informal education? And is there an official certification? If so, is it federally compliant?
There is no, this is Deborah Billingsley. There is no official certification that you have to have once you get your degree. then that's all you need. Anytime there are new drugs that come on the market, generally what happens is they will get continuing education, and that's often provided by, sometimes it is provided by a drug company, but it could be provided by just different groups that are dealing with it. So they learn from continuing education, they learn from talking to each other. In fact, I checked in Connecticut because they were the first state that actually started requiring the pharmacist to be involved, and so they did have a little bit more of a learning curve. But since that time, they stated that what they did was they just did experimental, and they worked with the patients, they worked with the doctors, they tried to figure out, they started low, and they would just gradually add more of the drug to see what the outcome would be. They kept records, and they shared with each other. And I can tell you at this time, there's now a lot of continuing education out there that is on medical marijuana, and a lot of that is being offered in Oklahoma.
For a follow-up? Okay. Leader Copeland, you are recognized for a question.
Thank you, Mr. Chairman. And thank you all for being here. There's a lot of information being given out, and it's kind of hard to keep up with all of it. But one thing that seems to be a thread between everyone is that you don't have any studies because of the legal problems with cannabis or marijuana in this country. And Mississippi State or Mississippi is the only one you seem to refer to. When I Google countries that have marijuana or use marijuana, there's a litany of them. Has anyone, I'm sure all of these countries aren't using it strictly as recreational. I'm sure some of it is medical in those countries. Have you looked at those countries' information or data that they have come up with as far as the medical arena goes, or does FDA restrict you from doing that? Or
Yeah, this is Jason Beeman, and that's exactly what it is in the United States, is that we're not allowed to do what's known as a randomized control trial, which is how we do all other medicines, that if I want to know if Tylenol works better than aspirin, I'm going to give one group Tylenol, one group aspirin. And physicians are involved in those studies all the time. We can't do that with marijuana because we can't provide marijuana to a patient at this point to do a randomized control trial. As in there are other countries that have been well ahead of the curve on this, Israel being the international leader, and there's a plethora of studies out of Israel studying all different types of conditions and whatnot. And I'm very familiar with that literature, so I want to be clear that I feel very educated on the studies and what marijuana is good for and what marijuana is bad for. I don't think that we're missing it. We're definitely picking up. We can infer from three different places. One is the randomized control trials that are being allowed in the United States, which are highly, highly restricted. And that's where the VA and PTSD and the Mississippi State Farm. The other way is we can infer from other countries, and it doesn't always come to our population exactly, but it's pretty good. And in medicine around the world, we learn from other populations, so we're doing that. And then number three would be that we can take patients that are using marijuana, even though we're not providing it to them or recommending it to them, we can take them and measure the outcomes, whether they be good or they be bad. And that's where a lot of the information comes from. There's this narrative out there that there's not a lot of research in marijuana, and I just don't buy that. I think that there's plenty of research in it.
For a follow-up?
Another issue that came up last week with the doctors that we had here was the issue of liability. Nobody today touched on any of that really. Would anybody on the panel like to touch on the issue of liability?
Well, physician conversations among us, we're quite concerned with that. Liability is diminished by having an excellent patient rapport. We know that. But we are concerned because we don't have any say in follow-up, any say in dosing, any say in medical conditions at this juncture. And so for us to issue this medical marijuana license for 2 years and have absolutely no idea, and what if their medications change? What if their illnesses change? What if they become addicted to something that we didn't know at the time, but that happened later? We really need to have that follow-up and that conversation. So we are aware of that, but it's what we deal with all the time. We've had talks with our attorneys about it, and the attorneys are very concerned. In our CME, Continuing Medical Education, through the Oklahoma State Medical Association, coming up, we have attorneys, healthcare attorneys involved in some of that presentation to help enlighten and ease some of our members who are concerned about the very thing you're talking about, sir.
Yeah, and Jason Beeman, I would say that third-party liability in the area of medicine is ever expanding, and definitely into the psychiatric drugs. There have been national cases involving benzodiazepines in which an individual was prescribed a benzodiazepine, had a car wreck, and injured somebody else. That person that was injured was then able to sue the doctor. Now, those cases are still going up through the legal and appeals processes, so we don't know how different jurisdictions are going to handle that. Also, the state of West Virginia has now made it possible to sue your doctor if you get addicted to a medication, specifically opioid. So as was just said, I think that we're really, really concerned on how doctors are going to be held liable here. If a person has a motor vehicle accident and they have marijuana in their system, are the other injured parties in that accident going to be able to sue the doctor? Also, if the patient develops psychosis or addiction from the marijuana, with the doctor not being able to pull back the prescription, not being able to, not seeing them every month and being able to regulate that, are those people then going to be able to sue the physician for those negative conditions?
For a follow-up? Yep.
My last question deals with, someone brought up the possibility of a person had VA benefits possibly losing those because they've used medical marijuana. Is that something that has happened, or is that just a fear that something might happen? And is that regulated strictly by the federal government and their actions, since they're the ones that would be restricting their coverage?
Yeah, Jason Beeman here, and I would appreciate the opportunity to clear that up. It is federally regulated, so specifically the veteran cannot possess or use the product in the VA property in any way, shape, fashion, or form. None of the VA prescribers can be recommending it. They can discuss it with their patients, but they can't recommend it. And then also, no employees of the VA can use marijuana, medical or otherwise, because it's all federally regulated. And as we've seen in a lot of different areas in our state, that it's the federal regulation that trumps, and those federal organizations will assert their authority in those realms. To my knowledge, there is actually an official policy with the VA that says you will not be denied benefits because of medical marijuana use. So if a veteran goes into a clinic and tests positive for marijuana for whatever reason they were testing, that in and of itself would not be a reason to deny them benefits.
Whether they had a card or not.
Right, whether they had well, no, I think they would have to have a card because if they're using marijuana not medically, then I think that would open them up to other discussions. And I'm not a VA disability physician, so I don't know how that is, but specifically the line item from the VA is patients will not be denied benefits for medical marijuana. Not marijuana, but for medical marijuana.
Thank you, Mr. Leader.
Excuse me, Mr. Chairman. If I could, Bob McCaffrey, as former Chief of Staff at the VA here in Oklahoma City, I can tell you that no patient was ever denied benefit because of testing positive for marijuana, because we took care of patients testing positive for marijuana for decades now.
And thank you for that. The chair has a couple questions because I didn't see another member of the committee. I'm going to stick on that VA because I had written that down. There was some statements about VA doctors not being able to talk to their patients about it and veterans losing benefits. So to be clear, so we're clearing that up, VA doctors can talk to their patients about medical marijuana, and they will not be denied benefits of any kind if they were to test positive on a state-based medical marijuana program.
Yes, that is Jason Beeman. That is my understanding. They can talk to their patients about marijuana. They cannot recommend its use, and they cannot complete any paperwork.
But they will not be, but again, to clear up, because there was talk of losing benefits.
Yeah.
Absolutely not. They will not lose their benefits. On December 8th, 2017, the VA made that crystal clear, and they have a memo on this. Is that right?
That is correct.
Okay. Thank you for that. There were some questions earlier, too, that this is such a confusing topic, because I've said to lots of people, I know absolutely nothing about this topic. So you hear things that are different kind of every week. Last week, we heard there were no studies on medical marijuana. I factually know that's not true, and thank you for confirming that. There's tons out of Israel. There's tons in the U.S. But I thought I heard you say, or somebody on the committee say, that there weren't studies showing it is effective for pain management. Did I hear that correctly?
Yeah, you heard that.
And for the committee, please, in the gallery, no responses. I appreciate it, but please, no responses. I'm sorry about the doctor. Go on.
Yeah, Jason Beeman, I said that there have been studies done. And, when we talk about studies, you have to evaluate the quality of the studies and the methodology. And the journals that they're in, you have to evaluate those sources. We know that the opioid epidemic was precipitated by flooding the medical literature with misinformation. And so the study that I'm quoting was out of Lancet. I believe it was in July. Lancet being the #2 medical journal in the world. It's a British journal evaluating long-term effects and consequences of marijuana on the use of chronic pain. There was no evidence to support its use.
So, but to clear that up, and I appreciate you saying that, because you're a scientist and I'm not. I mean, I'm as bad as it can get. I'm classically trained as a lawyer, so nobody should trust me. But what I would say is, I just want to clear it up. You're not saying there's not scratch that. There are studies that say it's effective for pain. There's just also studies that say it's not. Is that what you're saying?
Yeah, I would believe that that's correct. That there is a probably, there's studies on both sides. And so as a physician, we would evaluate that and say, well, there's some here, there's some there, we'd have to look. But I would say that this Lancet study probably trumps that, because it's one of the first major long-term studies with a very large sample size.
Okay, did you have a follow-up?
But I would agree with you that there is evidence that it does help for pain.
Okay. There was also some, and I'm just going kind of through my notes. Dr. Househair, did you say that there's not evidence? Did you say that there's not evidence that's effective for nausea, or was it kind of the same? Did I mishear that? Did you say there's no evidence it's effective for nausea?
I didn't say. I think.
That's why I'm asking, because I very well might have taken bad notes.
Yeah, I've got my notes here. If you give me just a second, I'll go back to exactly what I said. I think I was at that point talking, and I'll just paraphrase it. When we look at research, as Dr. Beeman had said earlier, you want to look at whether it's conclusive, whether it's probable, whether it's moderate, whether it's inconclusive, no conclusive evidence. It was the term I used. And so when you look at that type of thing, which is a very important distinction, we like to look at some of these things because we all hear case reports. You can see them, videos online from individuals speaking about this. And so I think it's very important to go back and look at what that evidence shows. And so my reference was from the 2017 National Academies of Sciences, Medicine, and Engineering, which is really, I think, the most exhaustive overview of all the literature. And I would invite you, because the source is right there and the exact language is there. There's a whole list of ailments that I described, and that was one of them, and it was inconclusive.
So you were saying, though, well, you brought me to another line of questioning, because remember, I'm not a scientist. When I was asking about pain relief on that, the specific study I was referencing was from the National Academy of Sciences, study 24625, for anybody that would like to look it up online. that was the National Academy of Sciences saying there was a 97% effective rate for pain management in that study. I'm trying, what's hard for me, and it's not you doctors, it's not at all, I think it's the topic, but what's hard for me is I think some of our terminology is different, because I'm hearing you say on nausea that we need to study the National Academy of Sciences and trust them, but when it comes to pain, a January 12, 2017 study, again, anybody can look it up, 24625, that's not the right one. How do I make these decisions? What do I look at? How do I know?
Yeah, Jason Beeman, I think, again, I think you're right. We are mixing up terminology. And I'm not familiar with the 2645 study, but I would be curious to know is whether or not it was acute or chronic pain, or was it a mixture of both? Definitely, I would say that the more recent studies would separate them out, because we used to mix them up a lot. We're continuing to evolve as a profession and as a discipline to separate those out. And what does chronic pain mean? What does acute pain mean? But there are also studies that show, I read one just last night that showed that in a study for acute pain that marijuana was no better than Tylenol or ibuprofen. I'm not going to base a lot of information on that study because I don't think it was a high quality study. So when I read that, I say, okay, there's something there that we need to be considerate of, but I would not change my clinical practice on that.
And Dr. McCaffrey, you had brought up the smokables. I want to go on record. I think smoking's a bad idea. I wish everyone would stop smoking tomorrow. But there's a difference between my opinion and what we should do under the law. There's a Florida case directly on point that is very similar to a ban on smokables that looks to me like had pretty, you talk about studies, I'm as a lawyer, the reasoning was pretty solid and it's pretty similar. The other issue I have as a legislator is the entire no campaign was based upon smokables. So I think it's hard for me to, I've used this phrase before, divine the will of the people and say they didn't intend that, when I think it's pretty clear they did. How do I separate that? I mean, the almost certainty of a lawsuit that we would lose and kind of going against what I think the vote says. How as I a legislator am I to do that?
Well, that of course is one of the key questions, because again, that's why we appreciate the fact that you're allowing us to present our information to you so you can try to use the wisdom of Solomon to solve those problems. And I don't envy you those. All I can say that as a scientist, we know what the ill effects are of smoking, of any substance. If you want to go back 100 years, there used to be cigarettes for asthma where you would smoke Jimson weed. And of course, we knew at that point that there is a beneficial effect on airway function from Jimson weed, but it also causes you to go mad and not be able to pee and things like that. So there are some side effects of that. We recognize that smoking is not an appropriate way to deliver a medication. There are cleaner ways to deliver the medication so you get the rapid absorption of the medication. And I'm familiar with the Florida case. I'm not familiar with all the arguments in the Florida case, but I think that the science behind some of the things that I have read is not very strong. So I'd have to familiarize myself a little bit more with that case to respond more knowledgeable to your question. But you're right. If you look at the common use of or the common delivery mechanisms for marijuana, while the use of smokables is going down in all the states that are monitoring this, it used to be over 50%. I understand it's now down in the low 40% of the people using marijuana for recreation or I suppose for medical reasons either. So people are finding other ways to deliver the marijuana. It still is a very popular form of delivery. And I think that part of that may be education on everybody's part.
That's fair. Yeah, Doctor?
I'd just like to make a comment. This is Jean House here. We recently, as a coalition, studied this topic as well that you bring up, which is an excellent topic, and it's a head scratcher. And one of the things we learned in our recent literature search, and we discussed among us, is the fact that the states that currently have medical marijuana, and let's just exclude Oklahoma in that, there has been a definite decline, anywhere from 3 to 7% in every single state on the smokables. Why? The inference is that people are choosing healthier forms or methods of dosing this. And so it's kind of like it's old news, smoking. That's like going out the door, because people are intentionally, just like they're trying to maybe eat healthier or exercise more, you know, they're also trying to do that. So I don't know if that's helpful to you. And I can get that information to this body here if that would be of helpful to you.
Always.
I'll write that down. I'd be glad to forward that to you. It's interesting.
And then, Chairman, if I may just kind of answer your question, back to the original question. Yeah. This is Jason Beeman. I understand that you guys are in a very difficult position of trying to stick to the letter of the law and the will of the people, and then also try to do the best thing for patients. And I would just say that I think that there is an important decision to be made that we're going to have to put public funding towards the smoking-related damage that's going to be caused, public health dollars, just like we've done with tobacco. We should do that. I think we're also going to have to expend monies towards addiction and psychiatric treatment also, so that we can help kind of, when those bad things do occur, that we have the resources to treat them. And that way it allows you still to have an avenue to honor what the will of the people was.
Okay. You have another? Yeah, of course.
I'm sorry, just one more thing. Justine Hauser again. The other thing, of course, would be is if you did, as Dr. McCaffrey was inferring, did permit vaping of medical marijuana, what people grow at home and what they do at home, you know, they're able to smoke. If that's of high importance to them, they can go that route.
I agree, and this will be my final question, and I want to start off by saying thank you for coming. If you felt like I do ask pointed questions, but I ask them of everyone. That's our job. And I guess I want to tell you what my takeaway is all of this, and I want to tell you if you think I'm wrong, that we all come into this with our own biases. I mean, you understand one of my biases is a mother who died of metastasized brain cancer, treated at the OU Medical Center and at MD Anderson. I obviously decided to treat her at OU Medical Center, so I thought I had a very high-quality doctor here in Oklahoma who told me he sent his brother to Michigan to be treated for his brother's cancer because they had medical marijuana. So that, when it's an oncologist that I trust and one of the most sought after in the world that we have right here in OU, that changes some of my opinions. I also sit through some of these, and we hear studies both ways. So I'm getting incredible information here, but is it safe to say, for the purposes of this committee, that even this group would agree there are studies and there are times where it is shown clearly medical marijuana can be beneficial and does have a medical purpose?
Yeah, Jason Beeman, I would say yes. We've been very open about that from the beginning. And as someone who has also worked in a cancer hospital, I would absolutely agree. And I don't think there's a member of the panel that would disagree with the oncologists that talked to you about your parent. I think what we would say is we would rather limit it to the conditions in which it's been shown to be beneficial, and then we would definitely want the committee to be cognizant of the harms where it's been demonstrated.
Okay. Further questions from the committee? Representative Fatgetter.
Thank you, Mr. Chairman. My question's going to be for Dr. Croft, and I'm going to make a statement, and then just in my statement there'll be like 3 little quick questions that are kind of yes/no deals. But and like the chairman, I've frustrated everybody in this room at some point or another, so it's not meant to frustrate you. But in your presentation, you talked about taxation, you talked about lobbyists, you talked about marketing, you talked about, you know, fixing pricing and all these different things. And so I did a little quick search. GoodRx, I can get coupons for Walmart, Walgreens, CVS, for medications that I would buy at those pharmacies. Do we have other medications that we have price fixing on? You know, I mean, I'm just struggling to understand that. Should we even be taxing medication, period? So that's why I said there's like 3 or 4 little questions.
I almost would respond to that question with a question, because the state's already set a tax rate for medical marijuana that's not applied to other medicines.
Mm-hmm.
So we're already treating this product differently than other medications.
I agree, and I've had a concern about that. So I've been saying we're opening up a, you know, Pandora's box by taxing this as a medication already. So should we continue to, you know, have those kind of policies in your mind? Should we be taxing other medications? Restricting coupon usage and marketing?
I am a substance use researcher in public health. And in the literature, it is established that the price point is what gives access to youth. So when we add taxes to cigarettes, the smoking rate for youth decreases. I'm giving you the information that we have. This is a brave new world for this state, and I think we are all going to try to figure this out the best way that we can.
Okay, thank you.
With that, I want to, if there's no further questions, thank you very much for coming. It was longer than we all anticipated. Thank you for being here. We will be having our next meeting Wednesday at 9 o'clock, and at this time, the meeting's adjourned.